Are you able to hear me?
Yes, we hear you. Thank you very much.
This is the Deputy Clerk just informing everyone that we are now live on the internet. Thank you.
Hello, Peter. Would you like to do a mic check? Peter Antons, can you hear me? Douglas Press, would you like to do a mic check?
Yes, can you hear me?
I do, thank you.
Thanks.
Colin, can you hear me?
Yes, indeed. Loud and clear.
Okay.
Jackie Lauser, would you like to do a mic check?
This is Jeff. Hi.
Hi, we hear you loud and clear. Thank you.
This is Jackie.
Great, Jackie. Thank you so much. Yvonne Karanas, would you like to do a mic check?
Hi, it's Yvonne Karanis.
Nice to hear you. Thank you.
Thank you.
Peter, for some reason, I don't see a microphone near your name.
Hi, Nancy. This is Paul Lorenz.
Hello, Paul. Welcome. Thank you. Will the caller ending in 936 please identify themselves? You will have to unmute yourself.
This is Kamal Sodi,
Thank you.
product manager. Thank you.
Good afternoon. This is County Supervisor Joe Simidian. Let me check with the staff from the Clerk of the Board's office and ask if we are ready to call the meeting to order.
I believe we are. It is after 2 and we're ready to go.
Thank you, Colin. And I can't see on my screen for some reason. Let me do that. There we go. I do see my colleague now. Thank you. All right, then the hour of 2 o'clock having arrived, we will call this meeting to order. And I know that the clerk likes to call the roll, even though there are only a couple of us, so go to it.
Supervisor Ellenberg
I'm here.
and Supervisor Simidian.
Present. Thank you very much. A quorum has been established. That takes us to item number 2 on our agenda, which is public comment. Public comment is that portion of our agenda set aside for members of the public who would like to speak on non-agendized items that are properly within the jurisdiction of our committee. Let me turn to the clerk again and ask, do we have anyone who has signed up to speak under public comment?
We do have a couple of speakers.
Great. I believe we allow up to 3 minutes for public comment. We're going to go ahead and ask you to post that amount of time. I will ask the speakers if they can be a little bit more crisp than that, so much the better. But if they need the full 3 minutes, the 3 minutes is available. Why don't we ask you to introduce the speakers in order, please?
All right, the next speaker is Ken Horowitz. I am unmuting you. Please accept the unmute. You will have 3 minutes to speak. The timer will start when you begin speaking. Ken, are you there?
Yeah.
Go ahead. We're ready. Ken.
This is Supervisor Simidian, and Mr. Horowitz's mute button is on my screen, so perhaps we need to ask someone to unmute him. Perhaps we need to ask Mr. Horowitz to unmute himself.
I apologize.
All right, I'm having problems getting Ken's audio resolved. I will go to the next speaker and then go back to Ken.
Thank you.
Next speaker is Scott Largent. I am unmuting you. Please accept the unmute. You'll have 3 minutes to speak. The timer will start when you begin speaking.
Good afternoon, everyone. Scott Largent. Hopefully you can hear me okay. Yesterday, I had an interesting experience driving up First Street. I understand that we're not putting people into the Santa Clara County Jail right now. I understand that we're not putting people into the psych wards and we're not really helping people on a behavioral health end. Is it because people are too scared to go out and talk with these people? I am just confused on why we don't pull people out of these situations. So this gentleman that was on First Street, I come driving up in my van, an African-American man, his pants are halfway down. His penis is just flying everywhere you could imagine. I mean, it was a shocking thing to see. And the man had so much head lice and bugs all the way around him. And the way he was scratching his body, and it was unbelievable. It was one of those calls where you're like, okay, this man is going to get help. They're going to come out and help him. Finally, down the road, a San Jose police officer was pulling up. And basically, he pulled up and told that man, look, nobody wants to see that, kind of put that away, blah, 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 and sent him on his way. From that point, he makes it down off of 2nd Street, and he's doing the same thing. Bizarre behavior in the middle of the road. He's not making any sense. He doesn't know what planet he's on. And these lice and insects are just basically jumping out of his hair. Now, so you guys understand, this is all film. So you can kind of get an idea. There are thousands of people like that downtown right now. And I am puzzled why nobody is doing anything right now. Do we need to get hazmat suits? Do we need to have, I just think people are chicken. They're scared. Put on a mask and go out and start talking to these people. And why is behavioral health on Santa Clara Street? How can you operate a behavioral health system from home? Nobody is working there. It's a ghost town. That's an empty parking lot right now. But guess who's going to the parking lot? The mentally ill, the homeless. They're having panic attacks. They're having meth-induced psychosis. They're living in those lots. We could get some people out there. I mean, why am I the only person out there? Why is Robert Aguirre the only other person out there? Where are the people from the county? Where are you people? I just, this is frustrating to see, because 5 years ago, I was one of these people. I was one of these people that was left on our streets to die. And now what? I'm 5 years sober, doing the right things to become a father. There are other people out there that can be pulled out of poverty. Okay, they can be pulled out of drug addiction. But we don't do that here in Santa Clara County. You land on your feet, you land on your face, we don't pick you back up. Please start helping these people. Please get more people out there. In the entire downtown San Jose is our new psych ward right now, which is very shameful. So thank you.
Our next speaker is Ken Horowitz. I am unmuting you. Please accept the unmute. You will have 3 minutes to speak. The timer will start when you begin speaking.
This is Dr. Ken Horowitz from the Health Advisory Commission. And I just wanted to give a shout out to our emergency medical systems, and the EMTs, the paramedics, the fire departments. It's been a really tough time with the pandemic, and with the heat, and recently with the fires. And these people are responding to thousands of calls, 911 calls per month. They're transporting thousands of patients to the hospital's emergency department rooms and the help that they need. So I just wanted to say to all these people that
We lost Ken. His connection dropped. Sorry about
All
that.
right. I think regrettably, we're going to have to let that be the extent of the effort, having tried twice to the clerk. Please convey our regrets to Mr. Horowitz, Dr. Horowitz. And if he reaches out again, let's try and make sure we have him squared away on technology if the challenge is resolvable from our end. Anybody else on public comment looking to the clerk to confirm?
That was it.
Thank you very much. Then having concluded public comment, that takes us to item number 3, which is to approve the consent calendar and changes to the committee agenda. And what I would say to my colleague, Supervisor Ellenberg, is we have a consent calendar that is proposed of items 11 through 18. If she is agreeable, motion to approve the consent calendar and to move item number 6, which is the recommendations relating to medical staff, up to become 4, so we can dispense with that item before we get into some longer conversations. Ms. Ellenberg, if that's amenable to you, a motion to approve would be appreciated.
I'm prepared to do that, but I would also like to make a brief comment on item number 14.
Please do.
This is the Valley Medical Center Foundation semi-annual report, and I just have to call out that it is nothing short of remarkable. The work that this foundation has done, particularly since the pandemic began, has been tremendous. I want to call out Executive Director Chris Wilder, all the VMC Foundation staff, and their board. They raised they collected more than $10 million worth of PPE on a range of other COVID response efforts that have served our vulnerable residents and support healthcare workers throughout this time. That's in addition to all of the good work that they do throughout the year. I want to also commend them on an outstanding fundraising event this past weekend. They went rogue and didn't move their event onto Zoom, as has been the case with organizations across the county. They put on an excellent event in a parking structure, and really you needed to have seen it to believe it. But congratulations and thank you so much for the vital work that you do to support vulnerable residents in our community. And with that, I'm prepared to make a motion to approve the consent calendar with the addition of item 6.
And we
Thank
do
you.
have
Item
a-
6 actually to be heard on just prior to item 4, separate and apart from the consent calendar. Forgive me.
Cool.
And that, all right. So
We
to
do
the
have
clerk
one
who's trying to get
public
my
comment.
attention, go right ahead. Let's hear from that speaker. For the record, I'll second the motion by Supervisor Ellenberg.
The next speaker is Sparky Harlan. I'm unmuting you. Please accept the unmute. You will have 2 minutes to speak. The timer will start when you begin speaking.
Hi, this is Sparky Harlan. Thank you for allowing me to speak today. And for the 2 minutes, I wanted to speak on item 12, which is the stakeholders' input to the Behavioral Health Department Mental Health Services Act process. I'm a member of the stakeholder leadership group for the Behavioral Health Department and have been for 2 years. And I wanted to say that the process for that group has been less than authentic as far as my input goes. We have asked for these town halls to be recorded at times so we can listen to them. I'm a little concerned because tomorrow I will be part of that process again for my input. And instead of being able to actually use my expertise of working with homeless, especially with young adults, I find what they do instead is they present us with stuff that's already been fully baked and programs they have designed themselves. And I really am reaching out to you so that you understand we would like to have more input into what the design and what models might be proposed, not just being given 3 models, vote on all 3. It's usually just up or down. And I particularly say this because we've done a lot of stakeholder input to do that mobile crises model that's similar to Cahoots. And I would like us to be able to have some conversation with the community about that more, but I don't see that that's going to happen. So I'm just bringing it to your attention that there's many of us on that group who have been concerned about this process today. So thank you.
The next speaker is Scott Largent. I am unmuting you. Please accept the unmute. You will have 2 minutes to speak. The timer will start when you begin speaking.
Thank you, everybody. Good afternoon, Scott Largent. I really always enjoy listening to Sparky Harlan speak. I really enjoy the public comments, and I mirror exactly what she's talking about right now. She knocked it out of the park right there. And my worries is I just hope that you 2 supervisors are just listening to this stuff. I know people kind of bury public comment. They don't really want to hear what the public has to say. They are not including any of the advocates, a lot of the nonprofits. They're not allowing them to come to the table. And with all this stuff, you guys are coming up with your own plan. Get life lived experience, okay? And you guys are not doing that. And this is not going to work out good. The city of San Jose is doing the same thing. They're just blocking everybody out. And the advocates that they do kind of bring to the table, it's like they suck all this information out of them and they just kick them to the side. And it's not like people need a medal or a plaque to hang it on. It's just people that are in the trenches, need a little bit of credit for them, for what they're trying to pull off. And you've got a lot of really good people, really good advocates. They come in there and they fight tooth and nail. And these are the superheroes of our community in my eyes. These are the real first responders right now. It is a war zone out there right now. It is an absolute war zone, and it's just going to keep getting worse. And we're not paying attention. Okay, I'm just going to leave it at that right now. We're not paying attention. Thank you.
And that concludes public comment.
Thank you very much. And I will just indicate on item number 10, we have a verbal report from the Behavioral Health Services Department, and Supervisor Ellenberg, was my thinking that if there were follow-up questions with respect to the comment we got a few minutes ago, we might ask for some comment at that time. All right. So turning again to the clerk, We have a motion on the floor and a second. The motion is by Ellenberg, second is by Simidian. It is to approve the consent calendar as contained in our published agenda and to move item number 6 up so that it precedes item number 4, which will make it our next item. Let's do a roll call. Even again, though there are 2 of us, we're trying to make sure we have a good, clear record here as we do all this virtually.
Supervisor Ellenberg
Yes.
and Supervisor Simidian.
Simidian, aye. Measure carries 2-0. Thank you very much. Consent calendar is approved, and our agenda now calls for item number 6 as the next item. So let me call item number 6, which is to consider the recommendations relating to the medical staff and allied health professionals. And Supervisor Ellenberg, I will just note there are a number of very specific requests here today or recommended actions, A through J. So when the time comes for a motion, we will ask for a motion to approve all items under item 6, A through J. And I believe we turn to the doctor for a report on the medical staff and allied health professionals. Welcome.
Good afternoon. Welcome. Thank you. My name is Yvonne Karanis, and I'm the president of the Enterprise Medical Staff, and I'm here to present the credentials report for approval and answer any questions. In addition, we have multiple revised and new privilege sets for approval, and we have the enterprise-wide attestation questions for both initial appointment and for reappointment for approval as well.
All right, thank you. Well, this is an important but relatively routine item. So in the absence of any questions or comments, let me turn to the clerk.
Supervisor Ellenberg.
I'm happy to move that we accept all items under item 4 and want to say hello to Dr. Karanis.
Hello.
All right. And just for the record, this is item 6, even though we have taken it up ahead of item 4. So we're both numbers are right here, but just so we know what we're talking about. 6A through J now being heard in the 4th position. Is that correct, Supervisor Ellenberg?
Yes.
Thank you very much. I will second. I don't believe we have any comments or public speakers on this one. Turning to the clerk to confirm.
We have no comments.
Then please call the roll.
Supervisor Ellenberg.
Yes.
Supervisor Simidian.
Simidian, aye. Motion carries 2-0. Thank you very much. That takes us to our next item, which was the originally numbered item number 4. And let's receive a report from Facilities and Fleet on the issues surrounding Child and Adolescent Psychiatric Facility, Behavioral Health Services Center on the Valley Medical Center campus.
This is Jeff Draper from the Facilities and Fleet Department. Paul, do you want to take it?
So Supervisor Simidian, Supervisor Ellenberg, we currently are on track. As you well know, we did go out to bid. We're thinking that probably by September 3rd, we should have a report out in terms of who we're going to select to do the construction of the facility. Design is on track. In fact, we will share a few pictures to give you a sense of how we're progressing on the facility. But again, we continue to move forward and are on schedule.
Thank you very much. Did you want to share those pictures now before I ask my monthly questions?
Sure. Curtis, can you share your...
Yeah, can you see that?
This is Supervisor Simidian. I can see it clearly. Thank you.
All right, Jeff, do you want to, if I steer the slides, do you want to kind of narrate through? This is the crunch down slide deck that the architects prepared for us.
Well, let's go ahead.
All right, start with the timeline.
So our timeline is unchanged, as Paul mentioned. We're on track to get the design done toward the end of January. We did select our construction manager at risk, and we're in the process of waiting for the protest period to pass, but we should have the award document ready by the beginning of next week, and we'll move forward with that. Next slide.
Let's see. Okay.
There you go. This is level 1. And Curtis, you're probably really much more familiar with all the program here than I am. So why don't you just go ahead and take a shot at it?
Sure. So on level 1, what we have here in the red represents the new version of emergency psychiatric services, also known as EPS. The pink is the pharmacy, which is in the middle. The orange color is the mental health urgent care. And then toward the far right is the administrative area in green. The next slide represents the second floor, which is the adult inpatient unit. They're essentially mirror images of each other. It recreates our 400 and 500 on the Barbara Aarons Pavilion. And then finally on the third floor, the top floor represents the child and adolescent services. So the blue on the left side is the child unit. The green represents outdoor courtyard space and recreation space. And on the far right is in purple, the adolescent unit. And sort of moving to the exterior, this is a rendering of where we're at right now. The footprint of the building sits directly across from the emergency department and between the Resource Services Center. And then just very finally, we're actually this week focusing on looking at exterior elements of the building. This is just a draft and one of the proposed looks for the exterior of the building. I think that's it.
And Supervisor, you would note in the renderings on each of the floor, there is outdoor recreation space. Safety for the staff and the patients were one of the major priorities in the design of the facility. So visualization, accessibility, et cetera, were all considered in this. And the design team actually spent a lot of time in looking at other facilities. So this is sort of the best in class in terms of design elements.
Let me ask 3 questions. The third one will be my standard about timeline, so all half dozen of you can get ready for that question. But the first one is, could you share any observations about what has been shorthanded in prior discussions as the importance of having med psych facilities? In other words, facilities that can handle youngsters who not only have the need for psychiatric services, but who have perhaps some significant medical issues as well?
So let me just first comment, and if Dr. Fong is on the line, she can also share her thoughts. But as you well know, typically when we admit an individual into an acute psychiatric unit, most of the expertise in those units are related to behavioral and not necessarily medical care. We will now have the capacity going forward with the facility to not only serve the behavioral health needs of the child, but also the medical needs of a child. And so we won't have to move the child in and out of the acute psychiatric unit to provide for those services. And that's something that is unique. And that's something that from a clinical standpoint, I think many of our staff are looking forward to. Less trauma to the child in terms of movement, et cetera.
Thank you. I do see Dr. Fong on my screen. Would you like to comment?
Yes, good afternoon, Supervisors Median and Ellenberg. Definitely, this is something that our community and our adolescent patient has been sorely needed. And from a clinician standpoint, this is extremely valuable from the perspective of bringing the right care to the patient instead of having the patient come to us. We come to the patient.
Got it. Thank you. And I don't know if Dr. Smith is on the meeting with us today, but if he or someone else from your team, Mr. Lorenz, could comment. I know at various times people have expressed just a certain nervousness about having the same facility or the same building serve both adults and children. Just thoughts about why that shouldn't be a source of concern given the way the design has been pulled together.
I guess I will start since you asked me. A lot of attention was placed on that issue as Curtis and the team came up with the design so that there's clear separation between the adults and EPS and the children and adolescents, so they won't be interacting with each other. They won't be in the same spaces with each other. The physical footprint of the entire building is the same, but all of the care delivery systems are different. So everybody will be safe and protected, and there will not be any opportunity for inappropriate contact. I guess, Curtis, you should mention from your perspective what you think.
You did a very good job. That's exactly what I was going to say, is that there's no real prohibition from having them in the same building. It's just that they have to be physically separated, especially on the inpatient side. And I think the design team has taken that element into consideration as they design entrances and egresses and spaces and workflows and so forth. So you were exactly
Thank you,
right.
Mr. Ohashi. You anticipated perhaps my next question, which was, does that mean separate entrances for the youth psych and the adult psych facilities?
Yes and no. So on the first floor, the adults for EPS and adolescents will be brought, the ones that need inpatient, from the back side of the building. The building also houses mental health urgent care, which is considered an outpatient area. And there's no reason for a separation for adults and children. It's similar to regular urgent care or emergency department. But in the inpatient areas and the egresses, you're exactly correct. We have separate entrances and workflows for minors and adults.
All right. Well, I'm going to ask that all of you who are working on this important project go back and give one more careful look to this issue, because if the first experience is at the walk through the door, and that's one that is problematic for any reason, even if it may not appear substantive to somebody else, it I think will be a cause for concern. So I'm just going to ask staff to go back and take a look. And I see my colleague Supervisor Ellenberg leaning in. So when I ask my final question, I'm going to turn to her for her comments and questions as well. And I'm going to go to Dr. Smith, and then Mr. Draper and Mr. Lorenz, and then Mr. Koenig and Mr. Ohashi and Mr. Sodi in order with the monthly question, which is, I see that we have continued, as you mentioned, to indicate that projected completion date, an expected completion date for design is February of 2021. Construction begins February 2022. And open to patients November 2023. Are we still on track to meet those deadlines? Dr. Smith, yes, are we still on track?
Presuming the asteroid doesn't hit.
All right.
Yes,
Then,
we are on line. We've had one disaster after another, as you're well aware, but this team is moving rapidly ahead and we're on track to meet the deadlines.
good. Including working with Oshpod? I should have asked that earlier. Forgive me, Dr. Smith.
I'll answer that for,
yeah, Jeff will have to answer that question.
All right, so Mr. Draper, the question is, are we on track to meet those 3 dates? And by the way, how are we doing with Oshpod?
We're doing fine with Oshpod. We've been reaching out to them to have our first permit meeting, if you will, and we're setting up a date as we speak. The indications are very positive. They'll meet with us soon. And the rest of it is all on track. We're doing very well.
Thank you. Mr. Lorenz, are we on track to meet those 3 dates?
Yes.
Mr. Koenig, are we on track to meet those 3 dates?
Yes, we are.
Mr. Ohashi, are we on track to meet those 3 dates?
Yes, we're on track.
Thank you. Mr. Sodi, are we on track to meet those 3 dates?
Yes, we're on track.
Well, then I'll say thank you ×6 and turn to Ms. Ellenberg and see if she has comments or questions at this time.
Thank you. I shared Supervisor Simidian's concern about mixing egress and ingress. When you showed us the first slide that had the lobby, my first thought was that looks like a corporate lobby, not at all child or adolescent friendly, but then heard you say that there would be separate entrances. So is there truly a separate entrance for children and teenagers that will have its own lobby that looks far more welcoming than this does? And I would also be very concerned if kids are crossing paths, not even because I'm worried about inappropriate activity, but I don't want anything else to, to scare or frighten children. I want them to come into an environment that immediately feels safe and welcoming. And to me, that separation is really critical. How do we get them from their cars up to the 3rd floor?
Maybe I can start with that and tell the committee first, when we come back next month, we'll spend a lot more time on this. Obviously, the question becomes, when do you separate kids from their adult family, and how do you do that? And do you do that before they enter the door or not?
Dr. Smith, I just want to make my question clear. I'm not talking about separating them from their own families. I'm talking about them not coming into contact with adults who are being brought into EPS, adults who are coming in to pick up medication, adults who are patients or potential patients in any way.
Right. Let us come back with you next month and we'll be able to give you the operational details, because at the beginning of the process, there is more policy separation. At the end, when they're in the caregiving, there's physical separation. But let us come back with it worked out in detail so we can give you a step-by-step and show you all the details so it's more clear to everyone.
Great, thank you.
Thank you.
And as we are very early in on this process, hearing from both of us that a physical complete separation from the very beginning is important, I trust will be incorporated in how the design goes forward. Thank you. Supervisor Simidian, I'm happy when you are ready to move approval of this report.
Thank you very much. Motion by Ellenberg, seconded by Simidian. Mr. Clerk, do we have any comment on this item today?
We do have 2 speakers at the moment.
Please, let's tee them up.
The next speaker is Scott Largent. I'm unmuting you. Please accept the unmute. You will have 2 minutes to speak. The timer will start when you begin speaking.
Thank you. Good afternoon, everyone. Scott Largent. I do appreciate the conversation today about the new facility that's going to be put into place at Valley Medical. You guys know I talk a lot about the psych ward there. I was a customer for about 6 hours, and the difference right now, and I'm not always trying to throw the ball, but the current setup there, and I know this is the adult end of things, they mix the men and the women, all the doctors and orderlies and everybody that works there is absolutely burned out from a failed system. And it really is one flew over the cuckoo's nest in there. That's what you currently have. So now I understand you're building this great brand new building, like we do a lot in Santa Clara County, but it's all show and no go. This is like what I talk about with the martial arts school. You see a lot of these ones that pop up, the Ernie Reyes schools, even ones out of Los Gatos. They have all the brand new bells and whistles, nice shiny glass, brand new charging stations outside. These kids can't defend themselves. They don't even know, they're not learning things properly from a traditional old school. So what I'm getting at is that's how I see things at Valley Medical with this psych ward right now. Mixing the men and the women, mixing the little kids together. Not to mention you have every person that can't get into that psych ward that's an adult is sleeping around there. They're defecating around there. They're smoking meth around there. You guys need to start going on field trips. So schedule one. And I don't think you'll do it, Joe, but Susan, I think you probably would. Go by there, set something up so you can go walk into that facility and see what I'm talking about. And I'm telling you something, you would be upset to see that. And what's really sad, when I was in there for about 6 hours and they had to cut me loose, women out of Los Gatos, Monte Sereno, Los Altos, that had mental health breakdowns are mixed in with meth addicts and just people that are just, it's just shocking. They are terrified in that place. Add insult to injury, make it harder for somebody. Thank you.
The next speaker is Robert Geary. I'm unmuting you. Please accept the unmute. You will have 2 minutes to speak. The timer will start when you begin speaking.
Robert Geary here. I have some concerns. Right now, I don't know exactly how many beds are available at the current facility, but I do know that I've had trouble getting people placed in there. Try to take people there that feel that they're either a danger to themselves or someone else, or they feel that they need to get some kind of care and get turned away because there aren't beds available. So I don't know how many beds are there. And I know that this new facility is a much larger facility, and thank God for that. But also, I don't know how many beds are going to be available there, because we're talking about something that won't be available for another 3 years. And given the current situation we have with COVID, we're going to have a lot more people that are stressed because of either having lost jobs or not being able to pay rent or getting evicted or finding themselves in a unhoused situation. Whatever, all these different things are going to put pressure on the population that's going to create a higher demand. And hopefully we'll be able to handle that demand. But given the current situation, the number of beds that are available and the availability of those beds leads me to think that I don't know if we're actually projecting the number of beds that we're actually going to be needing going into this next few years and then beyond that. So now's the time to look at this thing and see if we actually think there's going to be enough beds, or are we just going to put ourselves in a bigger hole in the future where, though we have more beds, we have more patients, and we still have no space for treating those people. So there's nothing more I can do but bring this up, and hopefully we've done that.
That concludes our speakers.
Thank you, Mr. Clark. And let me just confirm, I believe we have a motion from Supervisor Ellenberg to approve the receipt of the report. Yes?
Yes.
And a second from me. Yes? So if the clerk would like to call the roll.
Supervisor Ellenberg.
Yes.
Supervisor Simidian.
Yes. Then that measure carries 2-0. Thank you very much. All right, we have taken care of that item, and I believe that takes us to the item number 5 as published on our agenda, which is to receive the report from the public health officer, and with obvious emphasis on COVID circumstances these days. So, Dr. Cody, are you with us, or is someone else? I see you coming up on my screen, even though it says Jeffrey V. Smith. So,
yes. Hello, supervisors. This is Dr. Sarah Cody. This is not Dr. Jeff Smith. And I'm just going to give you a very brief update because we had extensive discussion yesterday. And primarily the update for today is that yesterday, quite surprisingly, the Centers for Disease Control and Prevention issued new testing guidelines that advised all of us that there was not a need to test people who were contacts to cases if they didn't have symptoms. And furthermore, if patients have mild symptoms, the provider could decide whether they wish to test or not. There's been quite a bit of discussion and pushback about that today. I think the state made some comments this noon. I know the health officer in San Joaquin County made comments, and Dr. Fensterscheib and I made comments publicly at noon today. We want to make sure that our community understands the importance of testing everyone who is symptomatic, everyone who is a contact to case, regardless of whether they have symptoms, and everyone who is an essential worker and may have increased risk of exposure. And that this is an absolutely foundational tool to controlling our epidemic. And so that's really the news since we were last together yesterday regarding COVID-19.
Thank you for that. Let me see first if Supervisor Ellenberg has comments or questions. Then I'm going to weigh in with some thoughts about the testing approaches that you just described. Thank you.
Thank you. Dr. Cody, I do have just a couple of questions today, but I also want to share with you a brief email that I get regularly from the same constituent. He is very persistent and asks the question on my community calls every Friday as well. And I don't have an answer to give to him from you. So that's what I'm looking for. He asks, what does the health officer think about the next several months regarding the COVID situation? It seems like we're kind of just bumping along the county at this point. Is this going to be status quo for the next few months, with the county staying on the watch list and a lot of businesses still forced to be closed? What does the health officer think might be needed to be done to get us off the watch list? The Solano County health officer said 95% of new cases are from private social gatherings, and it would be difficult to get off of the watch list. What would you like me to tell him?
Well, I would offer a couple of thoughts. Number one, I can't predict the future. Number two,
I lead with that.
Yeah, thank you. Number two, I think there's a couple of different paths forward. One path is if as a region or a state, we all became stricter, we could get out of this faster. Another path forward is to understand as deeply as we can where and why transmission is occurring and take a more focused approach. And that's the path that we're on. And so I do not have the same, I can't tell you with confidence exactly why transmission is occurring. And therefore I cannot tell you exactly which strategies are going to be able to knock it down. But what I can tell you is that that is the focus of a large body of work right now in our department operations team that's connected to the EOC, because we badly need to understand that and best strategies, and that's where we're focusing our work.
Right. So,
yeah, and I would also just say that I share your constituents' feeling, and I find it enormously frustrating that it feels like we're just kind of in a standstill, and it's very uncomfortable.
So you mentioned a couple of possible paths, one being a stricter and broader shutdown, and the other, which actually I think you didn't mention, but I know we're working on it too, is working with the state to try to get off of the watch list and to change the requirements for the watch list, which would actually allow us to open more. So those are two totally different paths: super strict lockdown, open more with good safety protocols in place. Am I able to share any sense of which direction we are more likely to head, or is this really a day-to-day game time decision?
Well, I think that we are in continual discussions. I am in continual discussions with my colleagues around the Bay Area, as well as colleagues at the state in two areas. One is to understand how could we proceed in a regional fashion. And as you know, we don't have we have regional organizations, but we don't have a regional government. So it's somewhat complex there. And the other is in the state is getting input around what indicators would be most meaningful to best understand the really, I guess, really understand transmission, right? Because each one of these indicators has some drawbacks, and we want the best sense of how we're doing. What we really, obviously where we want to get to is where we have suppressed transmission in the community. We can measure it and feel confident in our measures, and that it will look safe and be safe to engage in more activities. And I would say one of the most important activities is getting our kids back in school for in-class learning.
Well, I would agree. So I'm still giving people two really different answers then, which is, I think, adding to their frustration. Is it just as likely that we could enter into a period of stricter shutdown as greater opening?
I think that in our county, it looks quite different than it did in March, right? And so I think that we're all in a very different place than we were in March. And I think it would be enormously challenging to do something that was just within the county, which is why it's so important to have a regional or a broader approach to the best that we can, understanding that we really only have control over our county.
Right. Thank you. Thank you very much. I will share this response. I'll share the clip, see if that offers some, if not satisfaction, at least some satisfaction of response. So thank you. I appreciate that, Dr. Cody.
No problem.
I want to follow up on a couple of items with Dr. Smith, please. From the last update and in some policy committee meetings, I've made some specific requests that are still pending. In early August, the trend data tracking the number of COVID positive cases in the jails from the beginning of the public health order was taken down from the sheriff's population tracking page. I'd like to ask that dashboard, I'd like to again ask that dashboard be restored. Simply providing the number of current cases is insufficient. Can I get a confirmation that this can and will be restored?
Yes, we'll get it back up. I don't know when, but I'm sure we can get it back up within a week.
Within a week, terrific, thank you. At the August 6th PSJC meeting and again at the August 11th board meeting, I asked that we designate one senior staff member to be responsible full-time to coordinate across departments to assure that we fully implement prevention protocols, get to universal testing of jail staff, and plan for a safe resumption of critical programming and family visits for both our adults and youth in custody. Meg, I'm going to ask for confirmation that you have appointed Key Lee to oversee this role. Is that correct?
Yes, Key's working on that effort.
Great. Is he going to then start joining these meetings to report on this information?
Joining the health and hospital meetings, you mean?
Yes.
I can ask him to do that if the
or PSJC, either. We don't have to do both, but one of the committees should be getting a regular report on all of these issues, please. And happy to leave it unless Supervisor Simidian has a preference to your call as to which committee. I sit on both, so I'm agnostic.
At whichever the board would like is fine by me.
Supervisor Simidian, do you have a preference? I'm happy to take it to PSJC unless you'd like it here.
I think PSJC makes sense given the current composition of our various committees, because that will pull Supervisor Wasserman in as well and involve an even wider range of information sharing consistent with our committee structure.
Great, thank you very much. Next, I want to extend appreciation to the efforts of the contact tracing team to scale up and implement improvements to their operation. And I certainly believe that they need to be provided with every tool or dollar they need to support their system, staff, and outreach to connect with as many cases as possible. At the August 11th board meeting, I requested that data on the proportion of cases we reach, how quickly we connect, and how many cases and contacts referred are actually linked to isolation supports. I've asked for that to be added to the 5 key indicators webpage. And Dr. Smith, you indicated that this would be available by September 1st. So I just want to check to see that we are still on target for that.
As far as I know, we're still on target. I'll double check and make sure.
Okay, thank you very much. That's all of my questions.
Thank you, Supervisor Ellenberg. Dr. Smith, is Dr. Cody still with us?
Yeah, let me get her.
Thank you.
You're back on. Joe wants to ask you a question.
Hi, Dr. Cody. Thank you. I know you're all multitasking today. I wanted to follow up on a couple of the things that Supervisor Ellenberg raised and/or comments that you offered initially. In first couple of cases, at least, I'm gonna break some of my own rules. So bear with me, please. As a general rule, I try very hard to precede almost every communication on this subject with a reminder to my constituents that I am not a doctor and don't offer medical advice or opinions. And as a general rule, I try not to speculate about what somebody's or some organization's motives are. On the issue of testing, however, I want to just be very clear, understanding that you're the public health officer and the Board of Supervisors has a somewhat different role. I was pleased to hear you indicate that you had pushed back on what you'd heard from the CDC. My own view is that there is a growing tendency in many sectors of the health establishment and in the federal bureaucracy to address the shortage of testing by simply suggesting that we have less testing rather than suggesting that we need to step it up and providing more testing, which will be necessary both as a matter of health and economic resurgence in the months and years ahead. So to put it a little bit more plainly, I would like to see the conversation stay focused on how can we get the testing we need and get it out into the community as quickly and as broadly as possible, rather than have folks simply accept as a given the inadequacy of our testing programs and then justify that by suggesting that perhaps we simply don't need to do more testing. If you'd like to comment, you of course may. If you just want to say, hear you loud and clear, Supervisor, that's fine too. It's your call. But I didn't want to let that go unsaid, because I can see this as a growing narrative in some circles, and I think it is absolutely upside down.
I agree with you 100%.
Okay, thank you. And you know, as I say, I broke a few of my own rules. Then with respect to Supervisor Ellenberg's constituent, I have to say, maybe we share a constituent, or maybe we share hundreds or thousands in all seriousness who are asking the same question or questions for obvious reasons. And I want to share with you what I say, and this is me trying to recapitulate what I think I've heard from you and the rest of our county team, which going beyond my first two caveats, which are always, it's complicated and it depends, which is not very satisfactory, but which I've come to realize is the case. What I say to people is, you know, we've made a shift that was important but not much noted, and that shift is from sector-specific rules and regulations to an effort by our entire county to adapt to a new normal for the foreseeable future, and to do that by adapting our behaviors in a way that make as many activities as possible safe, as long as we carry them out in the safest possible ways. And you know, we know what those are for the most part. You've repeated them endlessly as a matter of necessity over these last several months. What I hear you saying is we will continue to try and open things up, but with clear expectations about how that can be done safely, and with rules and regulations in place to make sure that it is done safely. And if at some point we find that all of our best precautions aren't enough to keep us safe, or that there's insufficient compliance to keep us safe, then we may in fact find ourselves at a place where we have to tighten things up again and go back into a stricter shutdown mode for some period of time. Is that a more or less accurate understanding of what you've been sharing with our board recently?
That's absolutely correct. And so you are absolutely correct. Since the middle of July, we have had our risk reduction order in effect. And that is to both, as you say, to really emphasize that we must adapt to living with COVID It is not going away. And so we have to do everything differently. Keep our distance, wear our face coverings, and try to conduct as much of our lives as we can outside where there's better ventilation.
Thank you. And what I go on to tell my constituents is that in our own county organization, Dr. Smith has sent a memorandum out to all 20,000 plus employees that has said, in effect, you know what, we're going to be in this new normal at least through the end of February, and quite frankly, possibly well beyond. Does that also sound right to you?
Yes, it does. And I also want to emphasize that as much as we like to be in control of things, and as much as we have gotten reasonable control of things, we are not an island, and our county, in fact, is surrounded by the rest of the state and the country. And so we go where the rest of our collective goes.
Got it. I do want to just follow up on an issue that I raised yesterday with some additional data from today's reports later in the agenda. And it goes back to the question Supervisor Ellenberg was asking about our jails. And I'm not asking for anything in the way of a definitive answer today, but I am hoping that at some point, let's just say, could we talk about this a little bit more next month? The custody health data I have indicates to me that we had 2,300 inmates who were tested and that 54 of them tested positive. And the reason I found that number striking is that it's just barely a little over 2%. And I mentioned yesterday that the numbers were around 0.5% for folks in the homeless community, including those who are living in shelters. So I continue to be a little bit baffled by how we have 0.5% in a shelter setting or 2% in a jail setting where people are absolutely stacked one on top of each other, literally. And yet our countywide numbers are 4%, and the numbers in South County and East San Jose are in the 7 to 8 range. Does that surprise you at all? Is there something going on there that you can explain, or would you like to say, you know, gee, that's interesting, let us come back to you at the next meeting a month from now?
Well, what I would say is that we've had a tremendous emphasis on screening, so screening of inmates when they're booked, which we don't have in many other settings, and so with a focus on prevention of introduction of COVID into the jails, I think that may account for some of what we're seeing. Of course, introduction does and has occurred, but frequent testing, and not to put too fine a point on it, but a lot of those folks that were discovered to be COVID positive did not have symptoms, just emphasizing the importance of testing people even if they don't have symptoms.
All right, I will let it go at that. Let me confirm with my colleague Supervisor Ellenberg that she has no additional comments or questions.
I don't, thank you.
Thank you very much. Then we'll say
Thanks,
thank you, Dr. Cody. Thank you, Dr. Smith. Thank you all. Do we have comments on this item? Looking to the clerk.
Yes, we do. We have one comment right now.
Go right ahead.
The next speaker is Robert Aguirre. I'm unmuting you. Please accept the unmute. You will have 2 minutes to speak. The timer will start when you begin speaking.
Yeah, Robert Aguirre. I've been asking for a dashboard or some sort of accounting of the unhoused population and what their test rate is, how many people they have tested, how many people have tested positive or negative, and a follow-up of if any of them have been hospitalized or any of them have been treated or any of them have died from it. If we keep a record of that, I think it helps certainly people like myself that are going out to encampments have a better idea of how rapidly or how widely it's being spread. And I think it gives us a good picture of a certain population, just like we're trying to figure out how many men and how many women are victims. We try to figure out how many people of different ethnicities We try to keep track of all kinds of data like that, and I don't see why we can't keep kind of data available when especially most of the people that are encampments do not go to a place to get tested, but rather people come out with the Valley Medical Homeless Healthcare Program and do the testing out in the field. So it would be pretty easy to keep track of those numbers, but I don't see where those numbers are being reported. And like I said, that's certainly good information for someone like myself and other people that are going out into the encampments. So we know better how to either prepare ourselves or what to bring people, such as masks or gloves or hand sanitizer or anything else that might help with the situation. So especially right now, we're trying to up our push for census taking in the unhoused community. And it's good to know this. It's good to be able to pass this information on while we're doing that. And we're also trying to register people to vote. So these are all good things that are going to help everyone. And so I think we need to have that.
And that concludes our public comment. Up, Supervisor Simidian, your microphone is off.
Forgive me. Thank you. Motion by Ellenberg, second by Simidian to receive the report. Call the roll, please.
Supervisor Ellenberg.
Yes.
Supervisor Simidian.
Yes, motion carries 2-0. Thank you very much. That takes us to item number 7, which is to receive the report relating to direction of selected stroke patients to comprehensive stroke centers. Direction, excuse me, not selection, forgive me. And who's presenting today, please?
Well, that would be me. Hi, I'm Ken Miller. I'm the medical director for EMS. So you have a data dense document for you. And what I can do is kind of walk you through the question we set out to answer initially, and then encounter the complications of COVID-19. Quite interesting. So on January 1st, we changed the triage strategy for acute stroke in our EMS system to a severity only criterion, where it had been both severity as well as a time frame for symptom onset. That difference was a result of several key studies that indicated that the endovascular solution to acute stroke can be done much further out into a post symptom onset time period than had been the previous practice. Previously, it was up to about 6 hours. Several studies have taken it out to 16 hours and another to 24. So in consultation with our stroke CQI committee, our quality improvement committee, we decided to remove a time frame completely from our field triage and go entirely with acuity. Based upon our data from 2019 and before, we had been about a 3-year window or so where we did both acuity and time frame. We knew that about 85% of the patients in the field who presented with the highest acuity level of acute stroke did so within 6 hours. So we anticipated, of course, an additional 15% of patients being triaged directly to a comprehensive stroke center by removing that time frame and going along with acuity. Our concern was that additional patient triage and patient volume could inadvertently translate to delays in care because of the increased volume. So we looked at the time to intervention, which in this case is thrombectomy, the endovascular procedure that can be done at a comprehensive center, to see whether there was a time that interval changed over the first few months of 2020. Well, enter COVID-19 and things got interesting. So I can walk you through the report. I can summarize things first of all for you, and if you'd like, we can go through much more detail. But the essence of it is that when COVID-19, SARS-CoV-2 began to circulate in our community, things began to change. For example, even before the shelter-in-place order was executed, patients appeared to begin to no longer use 911 or other means of going to hospitals. For example, the the transport frequency for patients with cardiac-related chest pain began to decrease even before the shelter in place and continued to do so after the shelter in place. And other indicators did the same thing. Stroke transports declines somewhat, but later. It took a few weeks or so. The stroke transport rate continued to be the same, and then it declined for about a month period below the previous baseline, and then began to move back to find a new baseline very close to the previous one before the shelter in place and before the wide circulation of SARS-CoV-2. As a result, the number of patients presenting with acute stroke-like symptoms of lower acuity declined across January, February, and March in 2020 compared to 2019. The higher acuity stroke, however, as you could imagine, the more intense symptom presentation, patients were calling 911 and did make access to hospitals. As a result, with a decrease in number of patients, the metric of looking at time frame for treatment became interesting. As patient volume declined over particularly February and March and going into April, the metric for measuring time frame to the initial intervention, which is intravenous clot lysis, thrombolysis, actually went down. So there was more efficiencies with lower patients, as you might expect. However, in March and April, the interval for the patient's arrival until the beginning of the endovascular procedure, a thrombectomy, actually went up. Had there not been COVID-19, that would have worried us. That would have been an indication that an increase in patient transport may paradoxically be a compromise in quality. However, that interval came back down to its baseline in June, so we'll have to be watching beyond that.
Excuse me, Dr. Miller, I apologize, but just, you said something went up and I'm afraid I just didn't get it clearly over the screen. So would you go back to where I think what I heard you say is that the times actually went down, which is a good thing, even if it's for reasons we didn't anticipate. But what was it that went up, please, that caused the...
Right, two things happened. One, the thrombolysis or intravenous clot lysis times went down, but the indicator we wanted to see, which was a time frame to the initiation of endovascular procedures, the clot removal, that went up in March and in April. And again, had that not been for COVID-19, that would have been a warning to us that there may have been a paradoxical effect in contradistinction to what we had tried to achieve. However, those 2 months were unique. That's March and April is when both EMS transports and spontaneous patient walk-in and arrivals at hospitals for then laboratory confirmed COVID-19 began to increase and increase significantly. As well did the acuity for COVID-19. So not just hospital admissions, but ICU admissions also increased during that period. That was a tough time in EMS, tough time for hospitals, beginning to manage this relatively newish disease, but also managing patient care now with a much escalated infection control protocol and policies and practices. So those can contribute to complications, but not complications, to complexities in trying to accomplish sterile and detailed procedures. So the good news is that the interval for endovascular intervention went back down again to where it had been in June data. So as we watch going forward, we believe that the phenomenon of the increase in time interval for March and April were largely due to our COVID-19 experience and not due to the 15% or so, which is what was realized, increase in transports to our comprehensive centers. So that's our findings and bottom line for now. There's much more in the report, and we can continue our dialogue if you'd like to and go through it in more detail.
No, thank you. I'll turn to my colleague in just a moment, but let me just first ask a bottom line question, and I see Ms. Lowther on the screen as well. So I'll go to you, Mr. Miller, but certainly if your colleague wants to weigh in. So we have a protocol in place now. When all is said and done, to bottom line it, are you comfortable that the protocol we have in place is the right one for the foreseeable future?
Yes, I am on two accounts. One is it's where the science is guiding us. So that's clear in the stroke medical literature. And likewise, our stroke advisory group encouraged us to follow this pathway. And secondly, the aberration we saw in these time change, we believe is due to the unpredictable, the unanticipated COVID-19 phenomenon, and appears to be correcting. But of course, following this data forward, we'll confirm that finding.
All right, and then next question is, have the hospitals come to accept the protocol? You know, we went through a period a couple of years back, excuse me, where there was some resistance to the protocol. Do we feel like there's a broader acceptance at this point?
They have, and that was part of the reason why it didn't happen too close to the proximity of the release and the publication of those papers. Both papers chose slightly different time frames for treatment, and they also, and then AHA later recommended that a choice of time frame for intervention also be paralleled with the same choices for patient selection within those two studies. And that took some time to resolve with our comprehensive centers to decide which way they would like to go and to have some agreement. But by removing time frame from the EMS point of view, gave latitude to the comprehensive centers to choose and to work with the time frame they thought was best for their patients.
Got it. If I read the materials and understood them correctly, there has been a change in the number of, or an increase actually in the number of transfers from one facility to another, that has increased over the last couple of years. Is that correct? And if so, what's that about?
Yes, it has, and nearly all of those account for one of two things: either a transfer from a primary to a comprehensive center later in the patient's care to take advantage of the resources and rehab capabilities of comprehensives. So it's outside of the acute care window, or it's patient repatriation to a healthcare system.
Got it. And then let me say thank you for getting us some of the data that we've been asking for, at least that I've been asking for a while.
Sure.
And I don't want my mostly thank you to be diminished by asking, how about the fourth quarters of 2018 and 2019? I know that's data that the folks at the Stroke Awareness Foundation have asked for as well.
Yep.
Is that going to be forthcoming in the foreseeable future?
Yes, we have it, and our annual report for EMS, which is due to the state in September, will include the stroke data for the calendar year 2019.
And 2018 as well?
It's there. If it turns out, and I thought we had it, but if not, it's not a problem. I thought if the Stroke Foundation does not have 2018 data, it's there, and we can fill in the gaps.
All right. I'm going to ask you both to make sure that happens as quickly as possible. And then I'm going to turn to say thank you again. And then I'm going to turn to Ms. Ellenberg, who is up next.
Thank you so much. Ken, that was a terrific report. Thank you so much. And you actually preempted my questions about whether concerns about COVID had deterred patients from seeking care and whether that had observable impacts on their health outcomes during this period. Is there anything else that you want to add in terms of what you've seen?
Yes, there's a lot to be seen in EMS data that correlates well, for example, with medical examiner data and with public health data. The most relevant thing perhaps might be to say that we appear to be in a second round of COVID-19. Our EMS transports are up beginning about July 16. Hospital admissions are up beginning about June 21, so a little bit sooner. But the good news in this is, I guess, several fold. One is certainly in EMS, and I presume in the hospital care too, that we're getting used to managing, COVID-19 in the bigger context of healthcare and global patient care. The other thing is that this second round appears to be a lower acuity. So the numbers are there. In fact, the numbers are very close to what they were in terms of transports and hospitalizations back in March and April. However, their acuity and therefore their critical care admissions are less. So round two, lower acuity. I think we're getting a better folding in this whole phenomenon into global healthcare.
You're talking specifically about patients with the coronavirus, right?
Yes.
Are people waiting too long to go to the hospital if they're having to call EMS? Should we be messaging somehow that people should be going in sooner? what prompts people to call EMS? Is it generally a cardiac issue or a respiratory issue?
That's pretty wide, but what is interesting is why there was a gap between the increase in hospitalizations this time around and an increase in EMS volume. Whether that somehow represents a shift in a progressive acuity somewhat is a possibility. The data for other hospital transports within our EMS system is all trending back up again. So I think the appearance of the fear of people to, first of all, call 911 or to just go to hospitals back in late February and into March, that appears to be abating. Everything else is going up. So I think that may be less of the picture. But I can't account for that several week gap of hospitalizations followed by EMS transports this time around. Fascinating.
Thank you so much for that report. Happy to move approval when you are ready, Supervisor Simitian.
Thank you. And a second by Simitian, motion by Ellenberg. Let me check with the clerk. Anyone waiting to speak on this item?
There are no comments.
Thank you very much. Then we'll call the roll.
Supervisor Ellenberg.
Yes.
Supervisor Simitian.
Aye, thank you. Report is accepted. Ms. Lowther, Dr. Miller, thank you both very much. All right, that takes us to item number 8, and this is the specialty care, including skilled nursing facilities and dialysis services report from the Santa Clara Valley Medical Center. Mr. Lorenz, I see you leaning in.
Great, thank you, Chair Simitian and Supervisor Ellenberg. First of all, I think we all appreciate that when COVID-19 came about, there was a quite substantial decline in the number of outpatient visits. And that was a matter of design, but it was also in part related to individuals' perspective in terms of safety and fear relative to the unknown. And so what I can tell you today is that during that course, we have a return to about 85 to 90% of our outpatient specialty volumes. I would add also that during that course, there were certain services that were maintained because of their urgent nature. So services like cancer and oncology care, dialysis, renal care, many of these urgent and emergent types of outpatient services were maintained and currently are operating at 100% of capacity. Today, again, outpatient specialty visits are about 85 to 90% of their pre-COVID volumes. Today, because of the way in which we are now providing care, we are utilizing more phone, telephonic, and video types of visits. In specialty, we are running about 30 to 35% of those encounters being of that nature. And we continue to strategize in terms of increasing that availability and utilization. And just as a matter of information, some of our challenges is as much as we have the technology and the capability on our end, it's a matter of actually having that interaction where the patient has that technology and the ability to interface via video types of visits. So the vast majority of our visits right now are telephonic, and we are trying to push to video visits because those are more akin to specialty types of consults and interactions with our patients. So there is a big push in the system to figure out how we can crack that nut, if you will, in terms of our ongoing patient population.
Excuse the interruption, Ms. Lorenz. Did I understand you correctly to say that it really is as basic and simple as the fact that the folks who are our patients and clients just don't have the technology available to do the video piece of a telemedicine visit?
Yeah, it is in part in terms of trying to educate them in what they currently have available in terms of technology, but in some instances they don't simply have the technology.
So it may be that they have the technology, but are just challenged in terms of how to use it, given some of the developments of late.
Yeah, some of the nuances related to it.
Great,
yes.
Thank you.
So we are working on strategies. The other thing that I think we all realize that we did not start to ramp up elective surgical cases until June. And so there were several months in which we had held back for obvious reasons, to make sure that we had the capacity and the resources to deal with the initial surge. Since that time, I would share with this group that we are at 100% of our surgical volumes compared to pre-COVID times. And in some situations, such as at O'Connor Hospital and in a little bit at St. Louis, we are above pre-COVID volumes. And that is because we are working through the backlog of surgical cases that we had encountered. We would not be able to work through this backlog if we did not have the facilities available to us at O'Connor Hospital. If you look at the numbers, O'Connor Hospital in terms of surgical volumes, they're at 30% above what we were pre-COVID. So that has been a real benefit to our patient population to work down the backlog as quickly as we have. I can give you an example in orthopedics. It was just reported yesterday by the chair of the department that given the fact that we were partnering with O'Connor Hospital in terms of the OR capacity, we are now below 30 days backlog in terms of wait time for elective cases. And I just have to also preface that all emergent and urgent cases related to specialty surgical care have always continued throughout the COVID situation. So these are really elective cases we're talking about that we're able to bring forward and to work through as quickly. The other item that I would share with this group is that, as you know, that there's been a lot of discussion around skilled nursing facilities. As a system, that's something that we have focused on even prior to COVID. We were and continue to partner with skilled nursing facility in terms of leasing beds so that we have immediate access for our patients so that we can move patients that are no longer acute out of an acute bed. We continue to utilize that and partner with those skilled nursing facilities. They are challenged as a system. We're working with the county exec and others to figure out how we build subacute skilled nursing facility capacity. So one is DePaul. So long term, we anticipate that we would utilize that facility for subacute or a skilled nursing facility type of services, but also in the interim, if we need it for COVID related relief support, we have that facility. And the other area is at O'Connor Hospital, where we currently have a 26 bed skilled nursing facility, subacute for long-term ventilator dependent patients. We are looking to extend that contract and service so that we can expand the number of beds potentially going forward. So we are strategically looking forward in terms of meeting certain needs within the community. And we will continue to report back to you in terms of our progress in that regard. There was also a lot of questions around our renal care and our dialysis capacity at Valley. And if you've noted in the report that we do send a certain percentage of our patients outside of our facility because we only have so much capacity. You know, the fortunate thing is that many of these patients do come with a payer source. Many of them not only are on Medi-Cal, but they eventually qualify for Medicare. So there is access and capacity in partnering with many of the commercial dialysis centers such as DaVita and so forth. And we do have a good working relationship with them. We'll continue to monitor the financial implications of that in terms of outside medical costs, but at this point in time, there is capacity to serve those patients. And we do monitor them on an ongoing basis. So with that being said, what I'd like to do is just go ahead and open it up for questions. Dr. Phuong Nguyen is joining me on this item. If in fact you have other questions that I cannot respond to.
Thank you very much. Let me turn first to Supervisor Ellenberg because I see she's leaning in, and then I may have some comments and questions as well. Supervisor?
I just have to lean in to see the screen clearly. I don't have comments. Paul, when you do the 10B item, I'll follow up with some questions there. Thank you so much for this report.
You're welcome.
Thank you. Ms. Lorenz, I want to try and grossly oversimplify some of this. So please steer me back, and Dr. Nguyen as well, if need be. What I heard you saying is that we could use some more skilled nursing facility capacity and we could use some more dialysis capacity, and that there may be capacity at the two newer hospitals over the long term. Did I get the basics right there?
Supervisor, specifically for skilled nursing and subacute, yes. Dialysis chairs and of the like is a little bit more challenging in terms of how to go about doing that. It is a different type of facility and service.
If we've got the basic building space and shell, however, is it doable? And what are the pluses and minuses of considering that path? The reason I'm asking is my understanding is that the dialysis has the potential to not only provide a service for which there's pretty significant demand, but also to be generate some revenue for the system. Am I remembering those two things correctly?
So the answer is yes. We can redesign existing facilities. If in fact
I got a yes but coming here, Paul. I can tell. I can see that yes but coming. So go right ahead.
You know, so renal care and dialysis care is a business in which we, you know, obviously are interested in managing our risk associated with it and the cost associated with it. So it really is a cost benefit analysis that we have to go through. But I would tell you that in all instances, putting that aside, the system and our patients would benefit for increased accessibility internally to those services. And that is mostly akin to managing our patients within our system in terms of the continuum of care.
And so share with the committee, if you would please, then, so the reason we might be hesitant about that, beyond the fact that it's I hear you saying not an easy one to simply roll out, that it's is there, I mean, what's the impediment to moving forward on something like that?
I don't know that there's an impediment. I guess I'm referring to is that we haven't done the full analysis in terms of the financial implications, the cost benefit analysis.
Yeah.
And that's something that we would work with the county executive office on.
All right. Dr. Smith, you want to weigh in on this one at all, or is this just to be continued?
I can make a few comments. The skilled nursing facility issue is, I think, pretty clear. We need more capacity. We're going to need more capacity in the future. Population's getting older. We're all getting older and more need. And it's been reasonably easy to convert parts of DePaul to respite care. They are not at the level now that they would need to be to become skilled nursing facility care, but we do have capacity at O'Connor. And those are the kinds of things we'll continue to work on. In terms of dialysis care, that's a little bit more complex. First of all, a little bit about the reimbursement. This is probably more than anybody wants to know, but it's important to know. Medicare made the decision when it first began that anybody who needed dialysis in the nation, except for non-citizens, would get dialysis based on insurance through Medicare. And so the reason why places like DaVita and other dialysis outpatient units make lots of money is because they have guaranteed payment from Medicare. Except, as I mentioned, people who are undocumented or unwilling or unable to qualify for Medicare, those individuals still need dialysis care, and DaVita and those other institutions will not do their care. So we end up doing that, which is our job and was quite appropriate. but it's only to say that we're not as profitable as DaVita in dialysis care. If we had more capacity for dialysis care, we could be more profitable. And that's why Paul is trying to nicely say a cost-benefit analysis would be helpful.
Got it. All right, thank you. Let me, thank you, Dr. Smith. Let me ask a couple more questions and then we'll ask for a motion. Mr. Lorenz, could you tell us a little bit about, so where are we with ICU capacity at this point? And, you know, the constant anxiety that I think many of us feel, at least I certainly do, about wanting to make sure we'll have the capacity we need if we have another spike in COVID cases that requires higher levels of care, and this may also involve some update on where we stand with the surge capacity in a separate unit. So, what can you tell us about that?
Let me respond by putting this into two buckets. The first is which is our ongoing operations in terms of ICU capacity. So at Valley Medical Center, we have been over the past couple of years building our ICU capacity. In other words, increasing the number of beds that we have available for that level of care. And that's because in general, we're seeing a much more acute population that is coming to our hospitals and require that level of care. And the other thing that you see occurring is that at St. Louis Hospital, we are looking to expand the number of ICU beds, given the increasing number of Medicare patients that are frequently that hospital utilizing the emergency room. And then at O'Connor Hospital, we're also looking at our ICU capacity in terms of making sure that we've built out enough ongoing capacity operationally. Today, I can tell you that that's probably an area out of many of our inpatient services that we continue to see an increase in the number of ongoing patient COVID and non-COVID related. And we do have the capacity to care for those patients. The second category is, of course, is our surge capacity. And what we have done as a system was the 3 hospitals have identified up to another 200 beds that we can have available should we need them. And so we've purchased the appropriate equipment and supplies necessary to provide for that level of care should we start to be pushed in that direction because of the number of cases. And when I say we have the supplies and the equipment, that includes the number of ventilators that, as you recall early on, that it was a topic of discussion. And you know, I'll let Dr. Fong Nguyen talk about, you know, the types of patients that we're seeing today. You know, today, as an example, we have, I believe, 37 COVID positive patients in the 3 hospitals. 33% of them are in the ICU. And that number has come down. That number used to be a little bit higher, but we've been running around 33% of our COVID patients being in requiring ICU level of care. I'm going to ask Dr. Nguyen to kind of supplement with what I've shared.
Yes, so I only have some, I guess, like a short addition to what Paul said is that at the peak, we were at 62 COVID patient across the enterprise. And now I think for the last couple of weeks, we've seen a downtrend to the low 40s and high 30s. So we continue to monitor the number of patients coming in, and also based on the patients that are admitted, a significant higher portion of them are actually in the medicine unit instead of in the ICU as well. So that's a trend that we're seeing currently.
All right, thank you. And a change of subject, Mr. Lorenz. My recollection is that we're hoping the SAFE program will stand up in Santa Cruz end of this month, and I'm thinking the end of this month is pretty close. And of course, we've had to contend not only with COVID, but now the horrific fires. What's the status of that effort? I see you've got a couple of folks on the screen here with you who have been part of making that happen, and my thanks to you and to them again.
Yes, Supervisor Andrea Berolini is on the line. And maybe, Andrea, do you mind commenting in terms of our target date of the end of August for Santa Cruz?
Sure. Actually, Santa Cruz went live on the 24th, so it's been just a couple of days now.
Then I'll say congratulations and thank you, and please keep us posted. I see Ms. Walker has popped up on the screen as well. Anything you'd like to add?
No, we successfully went forward and we started at midnight on the 24th.
And any lessons learned? I'm just curious from, the effort to stand up the program in another venue.
It's definitely a different process, different workflows, but we've been able to mitigate any issues. Dominican has been a great partner and the Sheriff's Office is tremendous to work with. So we haven't had any problems, but if any do come up, they're really good about responding and creating solutions.
Good. Well, thank you again. Pleased to hear it, and thank you to all of you and to your colleagues who made it happen. Supervisor Ellenberg, anything else at this point?
Happy to move approval of the item.
All right. Motion by Ellenberg, second by Simidian. And let me just double check with the clerk that we have taken care of any folks who wish to speak on this item.
There are no requests to speak.
All right. Then we will call the roll.
Supervisor Ellenberg.
Yes.
Supervisor Simidian.
Simidian, aye. Motion carries 2-0. Thank you very much. That takes us to item number 9, which is the PCAP program. And, before we go, I see Ms. Walker and Ms. Berlini and Paul Lorenz all still on my screen. I know I said thanks, but I just sort of feel like we went by that a little quickly. I don't know how to say thanks an awful lot any more clearly than that. But, I think about the literally years that way too long that went into making this happen. And I wanted to pause before we go on to the next item, say thank you for your tenacity in making sure that we're able to make this work. Thank you. All right, now back to item number 9, the PCAP program. I think we're going to turn to Mr. Santiago for this one, yes?
Yes, and good afternoon, Mr. President, and then Mr. Chair, Simidian and Supervisor Ellenberg. Just a little bit of background. Primary Care Access Program was initiated in partnership with the community clinics, and based on the direction from the board, we wanted to accomplish 2 major goals. One of them is to provide access, improve access to primary care for the remaining uninsured, that is people that actually didn't qualify for Medi-Cal or Cover California. And then secondly, to strengthen the partnership with our community clinics. Here with me, I also have Michelle De La Calle, who's the current director for the Office of System Integration, who's the executive and lead of current implementation for PCAP, which is the short term for Primary Care Access Program. Over the years, as noted in the report, we modified the program to help us do several objectives. One of them is to leverage the county funding that was devoted for PCAP with federal funds. And by leveraging those funding streams, we were able to expand access to care at the community clinic sites. And then, of course, aligning some of the performance requirements for the program to some of the federal and other payer outcomes that we're looking to in terms of improving the care management. In the report, we give you an update in terms of how many enrollees we currently have and the number that we've had historically. It also gives you the breakdown in terms of the gender. Initially started off with mostly the mothers of the Children's Health Initiative. These were moms of kids that, as you know, were undocumented, and the moms were actually receiving care from our community clinics. That was the initial group, and they still make the majority of the recipients under this program, but it's a little bit more balanced, and 58% female and 42% male, as more people increase access and get regular treatment. It also gives you the breakdown in terms of the ages, which is not surprising. Many of them, the bulk of them, are between the ages of 35 and 64, which is the period where they begin to experience perhaps some early chronic conditions, but yet not qualify for other programs that are available for them. And then also gives you the racial ethnic makeup of the group, as well as the geographic distribution of the population. Our current situation is that the leveraging of the funding was done through the Global Payment Program. And the Global Payment Program was actually one of the 1115 waiver projects that encourage public hospital systems to develop an outpatient capacity so that we can reduce the burden on the emergency departments and the inpatient. And actually, this has helped us in that regard. And so what we've done is that we've been able to not only provide greater care and greater access, but also reduce the burden in terms of our hospital systems. That particular funding stream is one of the areas that has not been renewed. It ended in June 30th. However, what our team has been able to do, working collaboratively with our community clinics, is we have maximized the flexibility under the whole person care to actually do outreach and engagement, wellness activities for high-risk populations. And the high-risk populations in this particular case are not necessarily linked to Medi-Cal programming. It's actually could involve other populations. So what we've given you here in terms of the report is not only what the clinics have earned up to date, and it gives you a little bit of breakdown by each individual clinic, but then also our plan going forward, which is to continuously work and foster the partnership with the clinics, but more importantly, to continue to advance whole person care, treat the whole person, and be able to do that with other funding streams. That will conclude my remarks, unless you have any other questions in terms of the status. Under my director's report, by the way, I give you a little bit more detailed status on the whole person care and the waiver programs.
Thank you very much. And you're shaming me. I'm going to have to wear a tie to the next meeting, Mr. Santiago. I feel like you've raised the bar for us here. So thank you. I'm looking at the report, and I noticed that in addition to the gender and age breakdown, you've been good enough to give us a city breakdown, page 4 of 6 in the report, packet page 127. And I noticed that 9 of the cities, of the 15 cities in the county are listed. Are the other 6 not listed because they are less than 1% in terms of their utilization?
Correct.
And now I just want to warn you, here I come, Mr. Santiago, with a political question, or at least for me it is. So is it an accurate reading on my part then to say that the community that is the number 2 user of this program for low-income people who are literally making, less than 200% of the poverty line, the number 2 user is the city of Mountain View in my district, District 5?
Correct. And I presume some parts of Sunnyvale are actually also probably in your district as well.
Yeah, although given the economics of Sunnyvale housing, I would guess that I have less than half of Sunnyvale, and the Supervisor Cortese's district has, I think, greater pockets of need than the portion I do. But I was struck by the fact that Mountain View was the second highest, and just want to underscore that there are in fact significant pockets of need in my district as we have the conversation about how we provide services to all who need them throughout the county. And on that point, when I look at employed yes and no, I just thought it was striking, and this is on the next page, packet page 5 of 6. These are 64% of the folks who are accessing this program are employed. These are working people who, notwithstanding the fact that they are working people, are still at 200% or less of the federal poverty line, not prosperous by any reasonable definition. My recollection is that and I don't want to confuse folks by switching from PCAP to the healthcare access program that we worked on recently together, that the eligibility threshold there is much higher. Is it 400 or 500% of poverty? I can't remember. I apologize.
Yes, we went 400% with no payments and 400 to 600% with some payments.
Thank you. That was the fine point. Let me just ask you, I know there was some concern among some of our community clinics that when we rolled out the healthcare access program, which had a more liberal income limit, that might adversely affect our efforts to provide services through the PCAP program. How is that working out in your experience and observation?
Actually, it kind of aligns it much better, quite frankly, because the difficulty we were having is we had, even with the 0 to 200%, if they were coming into our system, they would have to do a whole nother financial screening process, and they would have to go through various doors. There was prompt payment, there was prepayment, there was a variety of different schemes. And as you remember, under the Health Access Program, we're able to standardize it, not only in our own ambulatory care centers, but also across all 3 hospitals. So at least for the 200% and below, it's trying to achieve a standardized patient experience related to the financial burden or potential financial burden of healthcare. I think the discussion point, of course, that is part of our strategic planning with our clinics is what are the changes that we need to make to ensure a standard and uniform, if not universal, experience across both the community clinics, our own county-operated sites. There is different financial screening methods and processes within each clinic. So not all of them use the same. So that's probably going to be one of the areas that we're going to be talking with our community clinic partners. If in fact they will also want to standardize the way we did it with the healthcare access program across all the community clinic network, so that at least from a patient perspective, they'll be able to see that as a universal experience, whether they go to a community clinic setting or one of the county-run sites. So it's a pending matter we'll need to discuss.
Thank you. And last question, and then I'll turn to Supervisor Ellenberg. Thank her for her patience. I know that the PCAP program, of course, and the healthcare access program that we're just talking about have the different income thresholds that we talked about. Is there any other way you could characterize the difference between folks who are using one program versus the other, or is it really just a function of income?
It's mostly a function of income. For example, particularly within the acute setting, we have people that may not necessarily use us for primary care, or they have other means. They could have a private doctor, for example, they go to it, but when they encounter an acute inpatient episode, they have a huge financial risk and obligation. So I think that at least on the inpatient standardizes that experience across the 3 hospitals. So we're trying to accomplish a variety of different things with healthcare access.
Okay. All right, thank you very much. Let me turn my colleague, Supervisor Ellenberg, for comments or questions at this time.
Thank you. Renee, can you confirm that the 6-month contracts have been executed with all of the community clinics to take us through December, the end of December?
I think Michelle has the latest one, but I think they've all received the scope of work. Many of them have already signed, and I think there's some that are still pending, but Michelle can give you the latest numbers.
Yes. Hi.
Hi.
We just received signature on 5, and we're waiting for confirmation of the scope of work detail on 3.
Great, thank you. I know that the clinics are certainly eager to get that signed and have one less thing to be anxious about these days. I want to thank you, Renee, for working with your team to find a way to extend the wellness funds to the clinic. These resources really seem like a win-win to further our COVID prevention work, especially in the communities. I'm so sorry, I'll get my dog out of here. Especially in the communities that need outreach and support the most and to stabilize our partners. So thank you for that. It sounded like the things in your report sort of ran into the 10B item. And I had a couple of questions there. Shall I ask them now, or are you going to present again in 10B?
Well, I could present again related to the waiver related discussion, because I know also Bert Margolin will give you a federal update on the waiver as well. So it's your choice. You could.
Okay, so these questions then are not about the waiver, so I'll ask them now. And I do want to just make sure I'm in the right item here. Yes. Let's see. So I want to thank Paul and all of the VMC staff for contributions on the COVID response and making a strong effort to look at operations and efficiencies to help close the gap. Oops, I'm sorry. I want to be on 10A. That didn't sound right. Thank you. What are the expectations for how HHS as a whole will work in response to the race and health disparities referral that Supervisor Simidian and I submitted to our colleagues that was approved on the 11th? And can you tell me how departments, especially VMC and behavioral health, as our large healthcare delivery systems, being organized to respond to this work?
Yes, and that was an item on 10, not necessarily related to PCAP, but I think one of the things that I'm talking with, obviously with public health initially, because public health has been leading the whole effort for not just our health system, but also for county government as part of DARE. But we also wanted to, as I understand your referral, look at much more closely in terms of the clinical care and the quality of care that we do and how that impacts different outcomes for different populations. So we're organizing a group of leaders across our health system that will be part of that organizing effort to address structural racism within our own care delivery system. We'll be able to give you some basic data distribution similar to PCAP in terms of our patient population. So you have a real good profile, along racial as well as geographic distribution in terms of the patient population that we serve, and therefore be able to give you a little bit of background in terms of all the things that we've done so far. Not to say that we're doing everything we need to, but at least give you a sense of what we've been working on up to date. And then also potentially some opportunities. So that way you have a real good comprehensive view, and then be able to engage you and Supervisor Simidian in terms of helping us identify further work that we need to do in this regard.
Great. I do want to make clear that this was not a public health question. I would be, and I'm sure Supervisor Simidian too, loath to put anything on public health right now. This really is about our system deliveries, and I am certain, given the disparate health outcomes that are largely racially divided, that we will find, if we're looking in the right places, that we will find places in our system where we need to make policy, structural, funding, other changes to make sure that we are not in any way contributing to those disparate outcomes. That's really what we're looking for, and what the heart of this referral is about, to look at our own systems. Right. What are we doing well? Where do we see negative outcomes or disparate outcomes, and what should we be doing better and differently?
No, absolutely. Oh.
Okay, great. Thank you so much. That's all I have. I appreciate that.
Great.
Thank you, Supervisor. Let me return to the clerk and just confirm. I believe we still need a motion and an action on item number 9. Yes?
Yes, and we do have a couple speakers too.
Okay.
Thank you. Thank you for the heads up. Let's go to the speakers before, and then I have one more comment / question for Mr. Santiago. But first, we'll go to the speakers.
The next speaker is Robert Aguirre. I'm unmuting you. Please accept the unmute. You will have 2 minutes to speak. The timer will start when you begin speaking.
Robert here. I just would like to Valley Medical Services, everything that they do. It's a wonderful organization. It's a wonderful people, and I'm very proud to refer people to it. I have no complaints about the system, and I want to thank also Supervisor Ellenberg for talking about looking within the organization to find out where the areas are there that are not being addressed properly, to reach out to the people that are not just low income, but no income, and people that are being left out of the system, and how we can improve things. I think it's a great attitude to have, and I certainly appreciate that. And I'd just like to point out too that all the data that's collected are tools that we use to better improve our approach to things, to be able to try to improve the services that we offer. And to that, I would also like to say that I too need tools. I'm out there in encampments, I'm out there talking to people, and whatever data I can collect from the county is useful to me, that I can use to go out and tell people things that they need to know, what things they need to be aware of, that sort of thing. And also for myself and other people that do what I do, to know what, not only what services are available, but what is the data? What do we have? And how does it affect this particular population for which I am most devoted and trying to be as passionate about. And so again, I implore you to try to collect that kind of data for the unhoused population, so that we can keep them safer, and the people that are also trying to help that particular population. So once again, thank you for the work you do.
The next speaker is Dolores Alvarado. I am unmuting you. Please accept the unmute. You will have 2 minutes to speak. The timer will start when you begin speaking.
Good afternoon, and thank you very much, Supervisor Samedi and Supervisor Ellenberg, for the time. And thank you to Renee for the presentation. Just a couple comments. We have respectfully asked Renee's office to please give us a little more time to review reports that are going to your board. This particular report we did not see until Friday. I guess it was posted on Thursday or Friday morning. And between Friday and today, we did find some inconsistencies in the data, which I think can be certainly clarified between Renee's staff and our staff. So I think we would just increase the quality of those reports if we had time to share and look at the data from both perspectives to give you a really wholesome presentation. And then the second piece is that we do look forward to some strategic planning with Renee, where we have a meeting time schedule or date. We're waiting to hear back from Dr. Smith's office, Renee's office, the health plans, so that we can look at this whole composition together, both for uninsured and otherwise. So with that, thank you so much. Just wanted to alert you to that.
Our final speaker is Scott Largent. I'm unmuting you. Please accept the unmute. You will have 2 minutes to speak. The timer will start when you begin speaking.
Thank you. Good afternoon, everyone. Scott Largent. Not trying to be off topic. I'm basically piggybacking off of what Robert Geary had to say. You guys understand that I kind of take this seriously as far as my activism and helping the poor and the homeless on our streets. Why is everything so different between committees? Why is the city, the county, they're on different pages? So I go to all these meetings and I watch them blame the county. I watch them blame the city. I watch them go back and forth. Why can't this information, this data that we're collecting, be out there for the public, out there for the advocates? As an example, there's a big, we already know the meth is bad on our streets, but there was a bad batch that got loose for the last couple of months that's been making people go absolutely crazy. They've been getting violent. They've been just going crazy. Why would we not want to let the homeless advocates on the streets understand that this is happening? We won't. And it's like we set people up to fail. We send them out to places, and I just don't understand this. I have also brought it to your attention that I have taken 2 COVID tests. Okay. I'm homeless right now. I'm living on the streets. I'm stuck in the struggle. I filled out the paperwork properly. I called the numbers. I have not been able to get my results back. Okay, I'm an open book right now because I want this to help other people that are getting these tests done. You have my authorization to figure out why I wasn't notified, what happened, what got lost in the cracks. You have somebody right in front of you that's it's an open book. Why would you not want to know that? Put pressure on the system, find out what went wrong. But we don't do that in Santa Clara County. Let's be honest, folks, we don't. So I appreciate everything, and keep digging in there, Susan. I really appreciate what you're doing. You're saying things people don't want to hear. I want to hear it. The public wants to hear it. And I support your leadership big time right now. You're one of my favorites up on that panel. So keep up the good work. Thank you.
That concludes our public comment.
All right, thank you very much. I think we have a motion, yes, from Supervisor Ellenberg. Forgive me, I just want to make sure we have a motion on the floor. Yes.
I believe so. If not, I will remake it. Just a quick note to Renee on the HHS reports. I would second that too, as well as for my own team who does the work to help prep me for the meetings. Having all of the reports in at the first available due date would be much, much appreciated.
Well, as long as we're on that topic, I will join my colleague in offering that encouragement, but it's hardly limited to any one office or any one committee. And so, you know, Dr. Smith and his team are on the line. I really do think that, you know, we all understand there will be times when we need to see some supplemental information that drops late for a board meeting. But that exception has unfortunately become the rule. And occasionally board offices are part of the challenge as well. I wouldn't be fair not to mention that, but it really does matter in terms of the quality of the decision-making our board is prepared to do, that we have the information in a timely fashion. And it also matters in terms of our stated commitment to transparency in the Brown Act. If people don't have the information, they can't participate in a meaningful way. So, Mr. Santiago, sorry you had to be the one to get the stern look and lecture today, but this is something I've been wanting to discuss more fully with Dr. Smith, and I'm glad that it was raised by the community, and that you've got two of the members of the board here today to say, hey, we really do need to see information on a timely basis. Having things drop late is a problem. And I will say, I don't know how it is for you, Supervisor Ellenberg, but I find it even greater problem in these COVID days because, you know, we're all scrambling to figure out where is this document, where is that document. You're a little more paperless than I am these days, but still, it's just, it's a challenge. All right, we have a motion, we have a second. We've got public comment taken, and so I think we can now call the roll, Mr. Clerk.
Supervisor Ellenberg.
Yes.
Supervisor Smidian.
Yes. Motion carries 2-0, and that takes us to item number 10. Yes?
Yes.
And Mr. Santiago, we lean in with you again, sir. Thank you.
Yes, and what we have here is an update from all the departments. A couple things that I wanted to note for you is in my narrative, I have an update on the whole person care, which we just finished discussing as part of the PCAP as well. So I won't cover that. We'll also give you an update on the waiver and the update, and Bert Margolin can cover that particular piece as part of his update, but just to let you know that that's a big priority for us. We're keeping it on our radar screen to make sure that we keep you up to date on those matters. I also wanted to introduce Dr. Day, Eureka Day, who I don't know if you were able to see Dr. Day, if you can come on, there you are. She joined us as the Director for Custody Health and Behavioral Health Services, and we're very happy to have her. She's part of now our executive leadership group. And at the same time, I want to thank Andrew James, who will give you the update for Custody Health Department, because I know there's some issues you mentioned a little bit earlier in terms of some of the situation and what's going on related to COVID. So Andrew James will give you that update. But I also want to take time to thank him for stepping in. I think Supervisor Ellenberg, you mentioned it already as one of the board meetings. But we're also very appreciative on behalf of our executive leadership team to Andrew for stepping in and helping us during that interim phase. That concludes my report, unless you have some very specific questions.
I just want to say welcome to Dr. Day, and I would love to schedule a one-on-one with you to get to know you. Wait a week or two. I'm sure you've got lots and lots to catch up on and get settled with, but I'll look forward to conversation with you.
Thank you very much. I should check in with our clerk to see if we have public comment on this item number 10.
There are no requests to speak.
All right, then no public comment. We will march through all of these items in good order. Let me just ask, let me just say first, I appreciated the update on electronic health records and privacy issues and data security issues that I'd raised with respect to behavioral health. It's at packet page 146. I'll just say I thought it was a little light on reassuring details, I'm just going to surface it again as an issue. And candidly, I'm surfacing it again as an issue because I'm hoping the organization is going to say, you know, we had a supervisor raise this not once, but twice. We better make sure that the commitments we've made to the board are commitments that are good going forward in terms of our data security for behavioral health information. I'll let it go at that. And I guess at this point, Mr. Santiago, we can go through B, C, D, E, F, and G. And so let's see if there's a verbal report again from Mr. Lorenz, or whether you've covered everything in your prior reports, sir. Up to you.
No, I covered most of the items. I'm sorry, Renee.
Yes, what we'll do is we'll have each of the department heads give you the status update for the departments.
Thank you. Mr. Lorenz?
At this time, I don't have any further update outside of what's in the written report. I'm happy to respond, obviously, to any specific.
Good. And Supervisor Ellenberg, I'll just ask that you lean in spontaneously if at some point we have someone that you have a comment or question for.
All right, I'm leaning in. I want to thank Paul and the VMC staff for the contributions on the COVID response and for making a really strong effort to look at operations and efficiencies to help close the budget gap. Really did a remarkable job with a very, very, very tough set of circumstances. I want to also thank John Mills for the off-agenda provided in follow-up to my June request. I was pleased to see in the follow-up emails this week that 14 of the unclassified employees have been hired into regular positions. Good progress. I know that VMC and the county as a whole are working on many fronts right now, but all of that work is carried out by our employees, and we need to prioritize getting these positions settled as quickly as possible, particularly before flu season or the next potential emergency takes us off course, which I'm sort of afraid to say out loud. I'd like to see the data on recruitment status for the remaining unclassified employees each month at HHC until all of these are settled. And again, really hoping that that's within the next month or two, that you'll tell me we're all done.
Absolutely, Supervisor Ellenberg. This is John Mills. We'd be happy to provide that information. And thank you for your comments about our progress. We are encouraged by it as well.
Good. Thanks, John. Don't slow down.
We won't. Thank you.
All right. That takes us to behavioral health services. And I think I see Ms. Rayo on the screen there. What would you like to share with us today? And could you perhaps respond to the earlier comment from Sparky Harlan?
Yes, good afternoon, Chairperson Simidian and Supervisor Ellenberg, Sherry Terrell with Behavioral Health Services Department. Related to item 12 that was placed on the consent calendar, that was related to our Mental Health Services Act plan. On May 26th, the request for a plan for a mid-year adjustment related to Mental Health Services Act was requested through the Health and Hospital Committee. And more specifically, the request was to look at our Mental Health Services Act plan and offer a process whereby the community and stakeholders could in fact, provide input related to how the Mental Health Services Act plan may need to be adjusted in order to address the needs related to COVID-19. And so we put together information for this committee, which details the planning process by which we are going to engage the community and stakeholders to gather input related to mental health service needs and COVID-19. You know, the first question we really asked ourselves was, how do we conduct a virtual planning process and still make sure we are being inclusive, given the fact that we are currently in a pandemic and, you know, there are just several restrictions that do not necessarily allow us to be able to engage with the public in the way we used to through large gatherings, et cetera. So what we've put together is a series of virtual meetings by which the public would be able to be engaged. We've also created online surveys for clients and consumers and community partners. We've offered those through SurveyMonkey in various languages, so we can gather input in multiple ways. We've also scheduled several virtual Mental Health Services Act town halls. And this is the option for those who still prefer to meet virtually and provide feedback during a meeting format. So we will be holding these virtual town halls with cultural communities to gather feedback from clients, consumers, and community partners. And these will be held through virtual opportunities for 2-hour sessions, and they will address COVID-19 emergent needs in the client and consumer communities, innovations planning, and overall mental health services planning discussions. So we really tried to be thoughtful about the ways in which we can offer multiple venues for people to participate. We submitted an off-agenda report in July, which actually highlighted some of the information that we gathered through other town halls that we have been offering across the county since April. And these took place during the onset of the pandemic and when there was really an interest from the community in gathering more information about COVID-19 and mental health. And there was a lot that we learned from those town halls, namely, we were really able to do better and improved outreach to unserved and underserved communities. There was quite a lot of participation through these virtual town halls, and many individuals who were surveyed after participation indicated that they had learned quite a lot by participating, and they really preferred this option. They could actually turn off their video and still participate and share and be able to ask questions in more of an anonymous format. And that really allowed them, one, to gather information, but two, to be able to offer their input. So we have outlined in the packet of information these 3 different phases by which we will be looking at our mid-year adjustment process. Phase 1 between July and August is a data collection and gathering process. Phase 2 between September and October are alignment of our priorities related to the Mental Health Services Act. And finally, in phase 3, it's really about the planning, review, and adoption of the information gathered through these different venues and bringing a plan forward to our stakeholder leadership group and to the Board of Supervisors for review and adoption. So I'm open to answer any questions that you might have. I do want to say I really appreciate the public comment that comes forward around our planning processes. I think there's always room for improvement, and we're really always eager to hear from the community about ways in which we can improve our processes around engagement. And so as we continue to engage in these different ways, both through the pandemic and you know, try to figure out different ways of engaging the community, we're really going to continue to be open to hearing different ideas that individuals and communities may have that would maybe be an improvement on our current process, because we really truly are interested in outreaching to as many individuals as we can to learn about what their needs are, and then being sure that we're able to integrate those needs into our plans and services so that we are in fact addressing the needs of the community. So thank you.
Thank you. Supervisor Ellenberg, anything else?
Yeah, Sherry, thank you. I really appreciate that recognition. There certainly is much more that we can do. And I know as you're thinking toward November, you heard loud and clear from all of the board members that your department is absolutely a priority. We're looking at mental and behavioral health services as important connectors with not only with COVID issues, but unhoused population, diversion from the criminal justice system, just kind of from every angle, kids in schools. This is what we're looking for. So you have significant support. We want you really to put these programs that I know we all want into place. And I know that it's a very challenging environment in which to do that. I want to thank you also for the comprehensive report on the current MHSA planning process that was on consent today. I think this expanded engagement is really critical, giving all the pressures on our residents and the need to shift services due to COVID to remote models. And I do think that it's important that we get regular updates on the feedback gathered and the thinking to guide MHSA and county resources for behavioral health. So please, I appreciate your keeping us informed through the monthly reports. I also wanted to ask, to what extent can the MHSA planning process also inform work on racial equity and justice, again, shifting away from law enforcement response to community and preventative models?
Sure. One of the guiding principles in our work going forward in terms of really thinking about how to prioritize our services, and this came both from our work together with the Behavioral Health Contractors Association. One of the key factors that we are continuing to consider as we have to make determinations about prioritizing services is the racial equity and social justice lens. And so as we begin to look at services and priorities, we are continuing to evaluate, who we are serving, ensuring that the Medi-Cal beneficiaries that we are required to serve as part of our managed care plan are in fact offered the services that they're eligible to receive, and continuing to examine within each of our programs, the different populations that are served and ensuring that we prioritize those that are most critical. So to your point, Supervisor Ellenberg, that is one of the guiding principles as we look at prioritization of our service delivery.
Good, I'm glad to hear that. And Supervisor Simidian referenced Sparky's comment. I just want to as well echo the importance of engaging that stakeholder leadership group before making determinations of options for services. Reaching out to individuals in the community is certainly critical. Also, please engage our community organizations that have this expertise, that have the cultural competence, that are in the communities and have been doing this work for a long time, which is not to suggest that our staff isn't equally qualified and competent, but let's work together and really build a culture of meaningful collaboration, particularly with our service provider partners, so that they are fully convinced that they are not vendors, but real partners, and that we are in this work together. That's something that I think is critically important to our success, our transparency, and our ability to build trust in the community. So it is a theme I come back to often across departments. Also, I know that behavioral health and VMC are collaborating closely on safety and COVID prevention issues at EPS and Barbara Aarons, which of course have unique issues to address. I'd like to request that a report be provided for this September meeting, similar to the one that Custody Health will be giving today, that outlines the testing, masking, and protocols in place to keep patients and staff safe from transmitting the virus. That's it. Thank you so much.
Thank you.
Thank you very much. And I'm going to say we can move on to the Valley Health Plan report, which is item 10D.
Thank you so much, Supervisor Simidian and Supervisor Ellenberg. You do have our report. I just want to provide some highlights. We do have over 22,419 members now for Covered California. Covered California at the state level has provided a special enrollment extension One is based on COVID-19 and the related economic damage that has extended enrollment until 12/31. In addition, we now have a special enrollment based on the fires, and that began on September 18th and will go to another 60 days till October 18th. That may be extended as well, depending upon how long the fires go on and how long those impacts last. In addition, we have 17 FTEs that are Valley Health Plan employees that are working to support the hotels and motels, housing vulnerable populations. We also have about a dozen, and as part of that 17, we have a dozen employees who are doing contact tracing and another employee supporting the public health department on investigations. And we are also looking at what we're going to do to support flu vaccine. It's a big concern for both flu vaccine and childhood immunizations, and we're working across the county in various organizations to ensure that flu vaccines are being provided. We're trying to remove barriers and work to make sure that people who have flu vaccines, places like pharmacies, can be reimbursed. So those are some of our updates. I'm happy to take any questions.
Thank you very much. Ms. Ellenberg, I'm good to go. Anything from you? And you're on mute, Ms. Ellenberg.
Yeah, I was looking for the button. No questions. Thanks so much, Laura.
Thank you.
Thank you. That takes us to EMS. Anything in addition to the earlier report?
Good afternoon, Supervisor Simidian, Supervisor Ellenberg. Just a couple things I'd like to highlight. As Dr. Miller pointed out earlier, our volume did start to go back up after the March 17 downturn. And in this report, we added to our abuse and neglect. And I just wanted to mention that we're working on a assault, abuse, domestic violence protocol, an all-encompassing protocol that will actually help the field with parameters and resources in this area. They're all aware of it. They're all trained. We did a really good job last year in October in the training of sexual assault as well as domestic violence. But this will give them something at their fingertips a little bit more. And in the data, in the third quarter, we'll have an overlay of the whole year with the first, second, and third quarter that will be an easier reference for you to see. So we tried to split out sort of the different areas. And even though San Jose is the largest area and has the most for domestic violence, it's actually South County that per population with 6.3 per 100,000 in Gilroy and Morgan Hill. So that was kind of interesting. And what we really looked at, and I looked at all the cases myself, was those cases, because out of 62 compared to, it didn't go up much after COVID compared to the 58 calls in the first quarter, was those that left against medical advice or those who refused transport. All of those had police presence except for one. And so we wanted to ensure that they actually had a police presence there so that those were taken care of. So, and strangulation was the only one that went up. This time, assault with no strangulation, 50 of the 62 with 12, whereas in the first quarter, there were only 3. So do you have any questions, or is there something else that you might like us to add to this data set? We can always add more parameters or anything else you would like to see.
Thank you. I think the only question I'd like to ask, and I don't know if it speaks to the data set or not, is we've talked about the fact that it seems pretty clear that folks are less likely to call during the time of COVID, yes?
The numbers didn't change much previous or after. It went up slightly, but the numbers didn't change much.
Forgive me that I may have misunderstood. So are we still getting the same volume of transports as we were prior to COVID then?
The non-transports were almost identical from first quarter to second quarter.
Got it. Thank you. Thank you for that clarification then. Ms. Ellenberg, anything from your end?
No questions. Thanks, Jackie.
All right. We'll say thank you. And I see Mr. Santiago leaning in, sir.
Yes, Mr. Chair, if I may, I want to give a special shout out to both Jackie and Dr. Miller and their whole team, 18. Small but mighty. They've been working 7/24 since COVID, and they've been working all the way through it. They've been deployed to ELC, plus of course with the fires and other things. I think they deserve some special recognition. And so I wanted to thank them as well as their team for all the efforts and all the work they've been doing.
Thank you for making sure we heard that.
Thank you.
That takes us to the next item, which is 10F, which is a verbal report from Custody Health.
Afternoon, Supervisor Simidian and Supervisor Ellenberg. Andrew James, I'll be reporting out for the month of July, the COVID-19 management effort that went in and Custody Health. So in the month of July, we tested 2,314 patient inmates, and out of 2% were tested positive. So 54 actually tested positive. We tested a total of 753 employees from adult and juvenile facilities. So from the patient testing, there were 36 that were confirmed. There were asymptomatic patients who were housed in either the infirmary or designated COVID-19 unit. Patients had daily vital signs and welfare checks, and this was done every shift by a registered nurse. 69 suspected COVID-19 patients were identified. Each patient was tested and housed in a single cell while the results were pending. And there were 120 patients who were exposed to confirmed COVID-19 patients. All patients were placed in isolation precaution housing for 14 days after the exposure and had COVID-19 test on day 1 when the exposure was confirmed, and then retested on day 5 and day 12 as well. There were 17 patients admitted to the infirmary, and these patients did have mild symptoms such as fever, cough, body ache, etc. Patients received around-the-clock nursing care, which included full vital signs and assessment symptom checks. Patients were also assessed daily by a physician. Medications for symptoms were provided. So we continue to have our COVID-19 containment plan. Each inmate that comes into through the booking area is tested. New arrestees who have no exposure to confirmed COVID-19 cases within 14 days are asymptomatic are housed in a designated risk management unit. And then from there on, they're sent to a 14-day separation unit where they are quarantined and before they can be housed for classification custody. In the separation unit, no new inmates are allowed to enter to prevent exposure. Cloth masks are given at the time of booking to all inmates. And in addition, inmates can request a cloth mask from custody health staff via the white card medical request process. And all inmates are strongly encouraged to wear masks when they're around people in order to keep themselves safe and others safe as well. And they're also encouraged to maintain social distancing and perform good hand washing. We were able to develop our staff surveillance testing program in collaboration with the Hospital Command Center, custody staff, and the Public Health Department. The plan was implemented on August 3rd. This program offers daily testing during morning and evening designated hours. Testing is available to all custody, sworn and non-sworn staff, and all custody health staff as well. Tests, which are nasal swabs, are performed by RNs. Staff members are encouraged to get tested every 5 weeks. And in addition to daily testing, we also have 2 full designated days at each adult correctional facility and 2 half days at the juvenile facilities for testing. That concludes my highlights for the report, and I'm happy to take any questions.
Thank you. Supervisor Ellenberg?
Thank you. I do have questions about some of the items in the report. First one, and I'm just going to kind of go by the sections of it. The first issue that's addressed is the policy for testing for inmates. We've never been given a firm answer on whether the entire jail the entire jail population would be tested as a baseline at some point when not necessitated by an outbreak, and whether there would be routine testing of inmates on a rolling basis to catch cases that might be introduced by staff or visitors, separate from the intake testing.
Yes, Supervisor. So we did test the entire jail when we had the outbreak, and following that, Dr. Cherney, our medical director, has proposed to retest the entire population, which should take place shortly, I would say likely next week. And moving forward, the plan is to test about 20% of the inmates as a surveillance, so part of the surveillance testing.
In addition to testing and quarantining them when they come in?
Yes.
Or isolating them?
Yes.
Right, it would strike me as more likely that if inmates are exposed, it's going to be from custody, correctional officers or attorneys or people coming in, if we know that they're clear when they get in and we've isolated them. So I think that routine testing of the staff is really critically important.
Yes, and that's going on right now. We did implement that on the 3rd of August. And so
right, it's happening every 5 weeks or so?
Yes, ma'am, that's correct.
Great, thank you. I have a question also about face coverings. It's unclear how many might be issued initially, what the process for collection and laundry looks like, just to make sure that they're changed out regularly, and how long does it take to receive an additional mask when it's requested?
Yes, so initially the masks are given in the booking area, and
I'm sorry, say that again, it got a little garbled.
So the masks are distributed upon the time at the time of booking when the
How many?
One is given, and they are required to keep that, and they can wash. They have a washing liquid which they can just use to wash, and at any time if they feel that if they need to replace it, they just put in a white card, and usually it's relatively quick. It's under 24 hours that the mask is replaced. And if custody staff, they call us and say somebody needs a mask, then somebody can just run it to the unit right away.
And inmates are told that they are able to easily request a mask, and it doesn't have to be because they've lost one or destroyed it. It just doesn't feel clean enough anymore.
That's correct, yes.
Good.
If it's oiled or if it's torn or anything, any reason, we can quickly replace that.
Okay. Great. On just a little bit more on testing for the correction officers, the report indicates that on July 11th, testing of 753 staff members were conducted, but I don't know what proportion of the staff this is. Is 750?
Yeah, I'd be happy to send you a breakdown, Supervisor. This encompasses custody and custody health staff. And
everyone, this is the full
yes, ma'am.
Count of humans?
Yes.
Great. So new efforts, so you mentioned that you're moving towards staff routinely being tested, but page 3 of the report indicates that this is still voluntary but encouraged. Why is it not being required? Can it be required? Is that a council issue?
Yeah, currently we're just working with the public health department and our hospital command center partners to see what can be done, but at the moment it is voluntary.
I didn't hear the end again.
It is voluntary at the moment.
Why? Why do we not want to make it mandatory? These employees are in high risk settings every day and risking exposure to a population that cannot protect themselves.
Yes, we are having discussions with the public health department to see what can be done, and at the moment it's just voluntary.
Doug, can you shed any more light on that? Is there a legal reason why we haven't made it mandatory?
I recall hearing these conversations. I do want to check with Rob Coelho. Obviously, it's a labor issue. I'm just wondering if it might be an MOU issue as well.
Could you get an off-agenda report to us explaining what the challenge is? Because certainly from a policy perspective and a public health perspective, like my colleague, I'm not a doctor, not giving medical advice, but it would seem to me that it's very much in the public interest to require employees to be tested regularly.
Yep.
Supervisor, let me jump in a little bit.
Go ahead.
It is a meet and confer item, and so there's discussion going on with the unions, and probably the best place for us to report this back would be in a off-agenda confidential memo to let you know what's going on.
Okay, thank you. I appreciate that. Face coverings, specifically a little bit more detail now. Face coverings for correction officers, where they're required to wear them, how often they're provided them. This information is not addressed in the report. I'm guessing because the response falls to the sheriff.
That is correct.
So this is an example of the challenge of not having had until now. Glad that Key will be on top of this, but an example of the challenge of not having a central person with oversight of all aspects of the COVID-19 prevention and response activities in the jail. We really have two disjointed systems that are tasked with caring for one population. Another piece that wasn't addressed in the report is information on the compliance level with policies in question, including how often officers and inmates are actually wearing the masks in practice. Do we?
As far as the inmate compliance goes?
No, you're talking about compliance from the health or the corrections officers, right?
Right, right.
Yeah, we need to get that from the sheriff because we don't have any independent way of monitoring that.
Well, we do have a way of monitoring it, at least on a spot check basis. To my knowledge, only 2 site visits have occurred at the jails to assess compliance since April, one by Dr. Redman and one by Dr. Hahn in their capacities as assistant health officers. So we should use the tools that we have. Again, we still bear responsibility for the folks that are in our custody. And I think we need to be doing everything that is within our purview and ability to ensure their safety, right up to wherever the sheriff's line starts, and we can't influence any further.
The sheriff had to invite Dr. Redman into the corrections units. So I think this is one of those things that's right on the line, and I don't want to take up the sheriff's side or anything, but it is clearly a problem, and I totally agree with you that we have problems with the delineation of responsibilities. So that's one of the reasons why we want Key to be involved.
Okay, well, again, Key won't have any authority over the sheriff that you don't have as the chief of corrections. So the issue is to do as much as we possibly can under the authority that we have. And certainly being able to be a conduit between the two would be very helpful. Doesn't get us all the way, but it would be better than where we are now.
Right.
So thank you very much. I appreciate that, Jeff. That's all I have.
Supervisor, if I can just interject briefly.
Sure, please do.
Davis and Captain Paget.
Oh, hello.
Hello. I do want to just reiterate, as we have in past meetings, that we.
Excuse me, Captain.
Yeah.
Could I ask that you please ask the chair of any committee to be recognized before you speak up?
My apologies.
Okay.
May I
So,
speak?
absolutely, Captain. Please go right ahead, mindful of the time.
Yes, was just simply going to say, we have invited public health to come in carte blanche, announced or unannounced without any issue. They don't need our approval We have put that in writing, excuse me. So they are more than welcome to come in and do spot checks at any given time, so that there's no red tape that we need to concern them with. That's all.
Great. I'll encourage them to take advantage of that open invitation. Thank you very much.
Thank you. Anything else, Captain?
Nope, that's it. Thank you.
Thank you. Ms. Ellenberg, anything else?
I'm all good. Happy to move approval of items 10A through F. Oh, do you want to include G? Sorry, do you want to have Bert's report first?
Well, I do want to have, I'll come back to you in a moment for that, but let's go now to 10G for the very patient Mr. Margolin, who I believe I saw, there he is, and ask you to share your report with the committee today.
Good afternoon, Supervisor Simitian and Supervisor Ellenberg. Let me start with the biggest unresolved issue in Washington that impacts the state and county, and that is the issue of whether or not there's going to be another COVID relief bill, and if so, when will it pass? We had hoped a month or two ago when last we spoke to this committee that this summer would see the passage of such a bill, given the desperate financial needs of both red and blue states. But we, instead of having a bill pass, we have an impasse this summer. That did not happen. The House did pass its own version of a COVID relief package called the HEROES Act last May, with $3 trillion in money, which included money for state and local governments. This would have had the impact or the result, if it had been enacted into law, of reversing the trigger cuts in Governor Newsom's budget that was passed earlier this summer. This didn't pass. The HEROES Act wasn't taken up by the Senate. The Senate instead, Republican leadership in the Senate instead, in late July, put out their own sort of counter offer called the HEALS Act, and that offer was priced at $1 trillion. There are many areas of difference between the two proposals. Just a couple of examples to cite for you. The House had $1 trillion for state and local governments, approximately $1 trillion. The Senate put in $0 for state and local governments. The House put in an additional $100 billion for the Provider Relief Fund. The Senate had $25 billion in their proposal. And then an issue of particular interest for Santa Clara County is the question of funding for testing and contact tracing. The HEROES Act passed by the House had $75 billion for these purposes. And the Senate bill actually has money as well. It has $16 billion. So there's a difference, pretty big gap between 16 billion and 75 billion, but it's good news that the Senate has put forward some additional funding for testing and contact tracing. Biggest stumbling blocks in the negotiation as we enter into the month of, about to approach the month of September, are that state and local assistance issue, the fact that there's $0 on the Senate side and over $1 trillion, nearly $1 trillion on the House side. That's a sharp difference. There's also a major difference on unemployment insurance, supplemental, the federal bump of $600 a month. The president, through an executive order, put out his own sort of counter offer, which amounted to something closer to $300 a month that would last for only a few weeks. The House is insisting upon $600 a month through the end of the year. That's being negotiated. Another big issue.
Mr. Margolin, excuse the interruption. You said $300 a month, $600 a month. Is it a month or a week?
I believe it's a month.
Okay, I just wanted to double check because we had some conversations previously about weekly amounts. So I forgive the interruption. I apologize.
Yes, I mean, that's my assumption that it's a month. But if I'm incorrect, I'll clarify that. The other big issue here involves liability protection for employers. The Senate has been insisting upon significant liability protection. They wanted to prevent employees from suing for contracting COVID, and the House has been resistant to that. That has to be worked out. Congress is scheduled to come back after Labor Day So it's hard, to predict exactly how this will resolve itself, except that the new conventional wisdom is that this will be tied to the end of the year, end of the fiscal year negotiation over a continuing resolution, the so-called CR, that is likely to be passed at the end of September. Mark Meadows, the president's chief of staff, made that point earlier today, that he thought this would be linked to the CR. Nancy Pelosi still wants to see this resolved independently, but the odds are that it will be, again, a CR related negotiation end of the year, given how late we are in the fiscal year. So that's the issue of COVID relief. Another issue I want to touch on briefly involves the question of virtual care, something that Mr. Lorenz addressed earlier on, whether or not our ability to bill for virtual care, telehealth, can be sustained. Right now, it's authorized because of a national state of emergency. A number of stakeholders, including Santa Clara County, tried over the summer to get our state law changed to make this a more permanent fixture of how we're reimbursed. Governor Newsom wanted to defer that issue, believing that the state of emergency is not going to end anytime soon, and this could be dealt with at a later point in time. And actually, the Republican convention sort of validated the governor's point, in the sense that the first night of the convention, the Republican speakers talked about the accomplishment of virtual care as a key signature issue for the Trump administration. So it's unlikely that we'll see virtual care taken away, reimbursement of virtual care taken away anytime soon. And at some point, there'll hopefully be an effort at the state and federal level to make this legislatively a permanent fixture in the way Medicare and Medicaid reimburse for services. Renee Santiago earlier on referenced the Medicaid waiver issue, which is also a matter of major concern for the county and for the state. The state was moving towards a negotiation with the feds over a smaller waiver before COVID and the COVID crisis. There's no capacity to negotiate a waiver in this environment, so the state instead has moved to a simple request for a one-year extension. That request is moving through the process now. The state this summer has had stakeholder meetings on the one-year extension. The feds are processing that request, and they have told the state that they're likely to reach a decision by the end of the year, maybe the start of next year. It's a little bit longer schedule than we would have been comfortable with. We would have preferred to have closure on this issue much sooner than that, but that seems to be the federal timeline. And the state of California at this point in time believes that they're on good footing with CMS and that we will get this waiver extension done by the end of the year. So we're not ready. They're not ready to push any kind of panic button yet. They think this can be worked out with the federal government, and they're looking at a decision by the end of the year. Another couple of issues to touch on, Mr. Chair, before turning it to whatever questions you might have. We talked in the past about the MFAR proposed rule that would completely disrupt the way in which the state of California puts up a state match for federal Medicaid dollars and create a meltdown in our state program and the need to reinvent it. There's been substantial opposition to that MFAR rule, and over the summer, CMS did make an effort to push that rule forward to OMB, try to get closure on it. A number of states resisted, including red states such as Texas. Texas played a very critical role in lobbying the administration and saying this would be a major problem for them, as well as dozens of other states around the country. Right now, that rule is still with the Health and Human Services Secretary. It hasn't moved on to OMB, so we're cautiously optimistic that MFAR won't suddenly surface at the end of this year, but there are people in CMS who are still strongly for the MFAR rule, so the risk is not completely gone. On the legal front, two issues, and I'll close with these final two issues. On the public charge issue that we've been tracking, there's been litigation pursued. A national injunction has been in place on public charge until only a week or two ago. And there was a decision in the Second Circuit about a week or so ago that essentially took down that national injunction and limited it only to 3 states of Vermont, Connecticut, and New York. So in theory now, even though litigation is still being pursued, the federal government could move ahead with public charge, but the Immigration and Naturalization Service says they're not ready yet. So while we don't have an injunction stopping them, we do have the federal government saying they've still got work to do before they can move ahead with public charge while the litigation is being pursued. And the last issue that I'll touch on or reference is Texas versus the United States, the effort by a number of states, 20 plus states, to overturn the Affordable Care Act through a lawsuit that's currently pending before the Supreme Court. We have talked before about, you've asked Mr. Chair in the past about timing on that lawsuit. Just a few days ago, the Supreme Court said they're going to hear oral arguments on November 10th. So it's just past Election Day. Again, it'll probably still factor into the election dynamic because those arguments will be fast approaching as voters go to the polls, but November 10th is now the date for oral arguments in the Texas versus United States litigation. That completes my report. I'm happy to respond to any questions you might have.
Thank you. As always, quite comprehensive, much appreciated. Before I go to Supervisor Ellenberg, I just wanted to go back and cover some ground that you already have covered, but I want to make sure I get the details right, or more than the details. So the House has passed the HEROES Act, yes?
Yes, in May.
And the Senate version is called the HEALS Act. Did I get that right?
That's correct.
And has that been acted upon yet?
No, it was
okay.
Unveiled, it was unveiled in July, but not acted on.
Thank you. So, and then, so obviously the two houses need to reconcile on something that will ultimately get a presidential signature. And you mentioned that the conventional wisdom is that it would be tied to what again?
The continuing resolution, which will fund the government at the end of this year. Normally you'd have the appropriations bills be signed into law. It's unlikely, given the dysfunction in Washington, that we'll have a normal budget process. So what's likely to happen is that we'll have a CR that will fund the budget for the federal government. And as is typically the case, contentious and controversial issues are tacked on to the CR. And Mark Meadows, the President and Chief of Staff, today said that he expects this issue of COVID relief will be tied to the CR. Speaker Pelosi hasn't agreed to that yet. She'd like to see it done before the CR is enacted. So there's a difference of opinion there, but there's a great deal of logic behind the CR being the endpoint.
And the timing again on a continuing resolution would be what?
September 30th. End of the federal fiscal year.
Got it. Okay, thank you. As my colleague Ms. Ellenberg's heard me say a couple times in other venues, I feel like we're doing everything we can at the county level to buy some time, but at some point we need our state and federal partners to step up and make some decisions so that we all know how we're going to proceed. Thank you. That covers it for me. Let me go to Ms. Ellenberg for comments or questions as well.
I don't have any questions. Thanks so much for the report, Bert.
Thank you.
Thank you. Then Ms. Ellenberg, the motion to receive the report under item 10 would be much appreciated.
So
yes.
moved.
And seconded by Simidian, and without objection, unanimous. Do you want to do a roll call there? Forgive me, Mr. Clark.
Let's go ahead. Supervisor Ellenberg.
Yes.
And Supervisor Simidian.
Simidian, aye. 2-0. It passes. Thank you. And I believe that completes our agenda today. Mr. Clark, anything remaining?
That is all items.
All right. Then I will say without objection and hearing none, the meeting is adjourned. Thank you all for your participation today.
Thank you very much.